Hi everyone, very good evening guys. I hope I'm audible and visible to all of you. A very warm welcome to the LRR for pathology. So a quick brief because we are meeting for the first time in these 4 sessions that I'm going to conduct. 2 of course for pathology and 2 for microbiology. As all of you know, we've gone through this drill earlier also. It's nothing new and you know it's going to be very high yielding. It's going to be a little faster than usual. And we are going to try that we don't sit for extensively long hours, but then at the same time we sit for a considerable time and we are able to cover up maximum of the syllabus and all the high yielding points, tentative questions, gut feeling questions that are for the upcoming exams. Before I begin, I hope all of you are aware of the INI-CET Champions exam that is upcoming on the PrepLadder app. That is going to be from April 23rd to 27th. You can give it anytime as per your ease and convenience. And this is going to be free for everyone, which will take into account all the real-time questions, clinical cases, image-based questions, and exactly how the pattern of the exam is in multiple sections. We try to simulate the same. Also, what's added this time is going to be audio explanation for every subject and every question that will come up in this Champions exam. So that not only tells you that the educators have cross-checked that particular question, but at the same time, they have also gone through it, double-checked it, they have added an explanation, and those will be your on-the-go revision steps, right? Now, also going forward to what is this session all about, I can come back and let all of you know that this is the first part which we are having right now. Today, my focus will be on systemic pathology for 2.5 hours approx. Tomorrow morning, we are meeting again mid-noon, 12 o'clock, and we are going to have general pathology and hematology. So my timeline is of 5.5 hours over 2 days where I will be able to wrap up all of this that is required for pathology, and then I'll tell you the plan for micro that will follow. But before that, a few questions which I've been getting all along, and I don't want there should be an interruption in our session going forward. Is LRR enough? And the answer to this will always be no, because if you're thinking that you can crack 100% of questions just while doing LRR of any subject, be it short or long, that's a very wrong approach. Of course, what I always say that if you've gone through RR or main videos and you club it with LRR, I think that's the best way of going forward. LRR alone is not for building concepts. It's for your last minute revision, as the name suggests. Now moving forward to, is it for everyone? Yes, it's for all. So that means that nowadays mostly I tell everyone FMG NEET PG has become pretty much at par, except the negative marking that's there in NEET PG, but the exam level questions are the same. INI-CET, there I would give a +1 there because there are few extra questions. So what I'm going to do in this session, wherever I say that this is only for INI-CET, only those students should focus on it. That's only going to be like 5 to 10 minutes extra for you guys, and the other students can take a quick water break in that. But that's just a way of saying that means you can also listen, but that's not very important for you. Also, at the end of all the LRRs, I will be giving an extra list for students who are preparing only for INI-CET for the topics which they have to cover before the exam, and they must go through it from the rapid revision. Of course, the PDF gang, before you come up, will you be giving the PDF, ma'am? Yes. Will you be giving the annotated PDF? Yes. But let me annotate it, means let the session be over, and then of course I will get the PDF put across to you guys, and it will be put across to you on Telegram. So be rest assured and do not keep worrying about the PDF. You have to worry about learning and answering in class, not about PDF. You don't even need the unannotated PDF because you don't have to sit and write. This is not the first time that you're reading pathology. Hopefully you've read it either in main videos or rapid revision or from some or the other source. So now you're not here for reading it and making new notes. You're here to answer, revise, and probably add on to things which you've forgotten. That's the agenda. So you will get a PDF which will be handwritten in my handwriting, but after the session is over. I think I have answered all the questions, and one question which I've been getting again, will this session remain after the live is over? Of course it will. It's not going to get hidden or will not fly away. So just get all the negativity and all the ifs and buts out of your mind and get on to focusing on the session. And I hope after this, no one will ask all miscellaneous questions and everyone will be focused. And that is why I've spent the first 4-5 minutes on this. So I think now we can start. And if you still have a doubt, which is apart from the session, ma'am, Telegram links and quiz and this and that, I think the best time to discuss would be after our session. What I want you to do over here is, with me, this 2.5 hours should be like a dedicated session only for pathology. Exactly. Like say FMG students have an exam for 2.5 hours. You'll have to sit with the same concentration for that time. Same goes for NEET PG and INI-CET students. In the exam, you have to have the same level of concentration for the same duration, and you cannot afford to think of miscellaneous things. And I want you to get into that tunnel vision and that zone of concentration where you're going to practice it with me over here today. Of course, there I won't be there, but you will be on your own. So you need to get motivated enough to only focus on what you have in front of you. On that note, since I said it's systemic pathology today, my main focus will be on cardiovascular system, respiratory, GIT, liver. Of course, I can never finish a session without renal and brain. This is what I'm primarily focusing on, the main chapters. After this, we'll obviously be left with the genital tumors, the breast tumors, and a little bit of, say, thyroid, adrenal, endocrine in general. So what I've done, like I do every year, at the end of the PDF, I have a few bonus slides, which means that once you are done all of this with me and you download the PDF, you will get only photos which I have already labeled. If you don't have time right now, oh, never mind. But one day before the exam, just go through these pictures and I think you will be good to go, because this will give you a good revision of surgery, medicine, gynae and other subjects. I think we are done with all the introduction and we are ready to go on to the real deal, and that is going to be the questions. I want to start off with the question which gives you the biggest confidence boost ever. You've seen this a million times. Some things are OG, you cannot get them wrong, and this is one of them. Autopsy diagnosis of myocardial infarction can be done by dipping the tissue in slices in a solution of course, ma'am, why did you get this question? Because I wanted all of you to give 100% strike rate in the first one. And the answer to this is going to be TPTC, triphenyl tetrazolium chloride, because it has 4 alphabets. We've always learned that it is going to be helpful in the first 4 hours of diagnosis if patient had MI for ischemia for 4 hours. Now there's of course a question which they ask you, that what exactly does TPTC stain? You know, today to save time, I have already written a lot of things so that I'm not wasting time in writing. This means in 2.5 hours, you will be covering matter of almost 4 hours with me. So be ready for that. And at any point you feel that ma'am I don't talk very fast anyway, so I don't think I will be very fast. But if at any point you feel that is, you can let me know. Okay, what does TPTC stain? Excellent, it stains LDH1. So how does the normal heart look like? You can see all of the normal heart over here is going to be brick red, whereas the area which does not have LDH, the area which has lost the LDH has become pale, and that will tell me it is myocardial infarction. Other questions that you get are to do with the microscopies. Very good. What is the first electron microscopic change? By the way, you see it within the first 30 minutes of myocardial infarction. And the first electron microscopy change is going to be mitochondrial swelling. Because no, many of you said waviness. Guys, hang on. Waviness is something you will see on light microscopy because you can see the cardiac fibers. I asked you the first electron microscopy, and mitochondria you will only see on electron microscopy, so don't make that error. Yeah, many of you said waviness, which is right, which you will see within 30 minutes to 4 hours, and that is when you will see the waviness and the vacuolization of the cardiac fibers. Please do not mess up on this question. Minor errors you make right now means you don't make them on the day of the exam. Finally, when do you see the first gross finding? And that is mottling. Mottling matlab, like you read in forensic medicine, it means color change, and that is something you will only see after 4 hours. After 4 hours basically means that within the first 4 hours I don't see any gross change in the heart, and that is why within first 4 hours I was using TPTC, triphenyl tetrazolium chloride. I think that is okay with everyone and we are settled. I have a few other questions. Why do you use neutral buffered formalin? That is the fixative for light microscopy. That is the fixative for light microscopy. Where is ethanol a fixative? This is a gynae question, guys. 95% ethanol is going to be a fixative for pap smear, which they ask you in gynae also. And these fixatives I am going to teach you somewhere today and tomorrow. So even if you don't write it over here, chalega. So I think first question, we've had a very good start. Now let's move forward to the second one. By the way, a lot of students had also asked me that, ma'am, do we have to go through the previous LRR? So this time what I've done is I have combined all the important questions from all the LRRs, put them into one, and I have added extra questions from version X and extra topics. So this is your go-to solution, and you do not after this have to view, you don't have time to view four LRRs. That's not the point of LRR, right? Moving on to the next question. What is the most likely cause stroke in a comatose patient, 50-year-old man with pancreatic adenocarcinoma who regains consciousness but dies after 2 days? So multiple etiologies. There's a stroke over here, there's a pancreatic adeno. The brain CT reveals a left temporal lobe infarction, but the autopsy given over here is clear cut of the heart, and we can very well, I've got answers. There is going to be vegetations. Now vegetations can be confused, but when I look at the history and I look at pancreatic adeno, I always think of NBTE, that is non-bacterial. It is not to do with a bacterial infection, it's to do with a cancer. This has resulted in thrombus formation. So what exactly is NBTE? These are the 4 which I want you to revise, and after path you have medicine LRR, which means we are doing the work for both the subjects. We have 4 types of endocarditis. These are the 4 different types of vegetations that we have. But the first question is, in the examiner might not write it as vegetation and will write it as verruca. So that pretty much means the same. Now when you look at the first disease, rheumatic heart disease, tell me two questions. How does the vegetation look like and what is the cause? For rheumatic heart disease, the cause is group A beta hemolytic streptococcus, which is also known as Streptococcus pyogenes. And look at the vegetations, they are very, very small, like tiny, tiny warts, so small warty vegetations. For infective endocarditis, ma'am, that's an entire microbiology LRR which you're going to take, because there are so many species of staph, like we can have staph aureus, like we can have staph epidermidis, then in streptococcus we can have streptococcus viridans, so many infections. But when you look at the vegetations, they are very, very large, and you call them large and bulky. Excellent. Moving on to the third one, that is NBTE. This is what I asked you, non-bacterial. This is not because of a bacteria. Example being cancers. Like you have lung adenocarcinoma, pancreatic adenocarcinoma. What is so common between these two? Both of them are known for releasing mucin. Guys, mucin is thrombogenic. Mucin is the one that is going to create all those thrombi, and then you can see these. Thrombi means, ma'am, thrombus is a blood clot. And a blood clot will break, right? So this is very good. This is going to result in embolism, and they ask you this question. I can see all those answers pouring in so much of abundance, which is like, why are you guys here? You know everything. And that is such a confidence booster, not just for you, but for me also, that we have studied somewhere on the right track, that we are able to get that information back to us, right? Now coming back, name one leukemia which can result in this, and that is AML-M3, because we all know AML-M3 is the only leukemia known to cause DIC. DIC matlab it can cause a lot of clots and thrombus, and that can cause NBTE also. Finally, coming to the last one, I don't think you need a revision here. LSE, Libman-Sachs endocarditis, rearrange the terms, ma'am. You will get SLE, that is one thing. You see vegetations on the upper surface and the both lower surface also, very, very good. But where do you see more common, lower or upper? So the way you write Libman-Sachs endocarditis, lower surface is going to be more common than the upper surface. Is that okay with everyone? Now coming back, over here I could not notice the exact vegetation, but when I saw pancreatic adenocarcinoma, I know I'm dealing with NBTE. They wanted to confuse you with cardiac mets, but you know that vegetations would not be seen in case of metastasis. Let me ask you an image-based question now that you've read it. See, the 4 images will be in front of you like this, and they will ask you, there's a patient brought to the emergency department by the paramedics. There's a chest pain. The patient had a history of advanced pancreatic cancer, and then following that there has been an MI and all the other features mentioned. There are non-destructive vegetations along the mitral valve. So now the same question, but instead of giving you a kind of wording over here, they've given you the 4 photos. It's the same pancreatic cancer, mucin production, ma'am, thrombus, answer is the same. Okay, so this is done. But out of these one more, everything I have not got as questions today. Otherwise, then you will be like solving an entire Q bank. Some things I've got you from one, like you used to have in a Viva, from one topic you derive another. So in rheumatic heart disease, if I ask you what is the most characteristic lesion, this photo comes a lot in the exam. And that characteristic lesion of rheumatic heart disease that you have is going to be ash of body. What is ash of body? So many times I've taught you that all the diseases with 3 letters are usually the diseases which are antigen antibody related, and are usually the diseases which show you fibrinoid necrosis. So although general path is for tomorrow, but you will tell me today. Fibrinoid necrosis is number 1 seen in 3 alphabet rheumatic heart disease. It is seen in a blood vessel disorder, that is polyarthritis nodosa, which I can see, and everyone's like, ma'am, minor things, hame pata hai, Anishka cells and all, your very baby questions, which is great. Another thing that is going to be SLE, and another 3-letter thing that is hypertension, but please be very certain it is malignant hypertension, which is going to be the case over here. So now coming back, in rheumatic heart disease, I will see fibrinoid necrosis, which I have marked in the center. And surrounding it, we see the Anishka cells. Anishka cells can look like 2 types. If they look like zigzag, like all of you told me, ma'am, that is going to be caterpillar appearance. And if it looks exactly round, that is known as owl-eye appearance, which basically means that this is the same pencil. If I show it to you like this is caterpillar appearance. And if I show it to you like this, it becomes a dot, that is owl-eye appearance. And now when they'll zoom in, they will mark it, guys. Pata hai, very good, but if you can't identify in a photo, then you are next to zero in the exam. So usually what they mark are these owl eye appearance, where you can see the round appearance very clearly. And of course, owl eye appearance, bola to ma'am, those two most ghisa-pita questions you will ask us. Which other owl eyes do we know in pathology and micro? Reed-Sternberg cell that you see in Hodgkin's lymphoma and cytomegalovirus to this. So we will talk about tomorrow. Third owl eye that you have mentioned are the Anishka cell. So Anishka cell, caterpillar cell and owl eye cell is the same? Yes. If Anishka looks like this, it is caterpillar, and if it looks like this, then it becomes an owl eye. We are done. Now this is the most, I'm not writing it, but this is the most characteristic lesion that you see, and that is ash of body. Previous year question for FMG students. I want to move on to a question which you must have seen in the recent QBank also. I've got you a lot of screenshots because I know time, it's just been launched. You've not gone through all the questions of version X. So I've done that work for you. I've got you a few screenshots. Lot of screenshots I've got you from the rapid revision also, because I want your visual memory to work. You've seen it in rapid revision, I want you to see it again. And I've taken a lot of screenshots, and I hope Prep won't ban me for taking screenshots of the app. I mean, I hope they don't. So 22-year-old man presents to the cardiologist with complaints of exertional chest pain, and there is shortness of breath. Once they say that a family history is significant of sudden cardiac death and of his brother at the very young age of 28. Whenever I see sudden cardiac death at a young age, I am obviously wanting to mark hypertrophic cardiomyopathy, and over there the mutation that is asked is going to be beta myosin heavy chain mutation. Okay, so when I say beta myosin heavy chain, either it can be written as MYH, that is myosin heavy chain, or sometimes it is written as MHC, beta myosin heavy chain. Both of them pretty much mean the same, guys. So if they write short forms, myosin heavy chain, or they write myosin heavy chain, it is the same. Please note, it is the beta one that is going to be responsible, and I can see that over here, because of which there are systolic murmurs, irregular heart sounds, and most common gene was asked. But how else could the question come? I mean, this to we know, ma'am, sudden cardiac death, but this is how I'm already telling you the answer. This is how otherwise the question could come. When you're talking about hypertrophic cardiomyopathy, their favorite question is a 19-year-old basketball or a football player who suddenly collapses on the court. Why has that happened? Because over here you are talking about a heart, and can you tell me that hypertrophy can occur anywhere, but this hypertrophy has maximally occurred where? At the interventricular septum. So if I maximally had to mark the hypertrophy, it is at the interventricular septum. And can you see what has happened to the left ventricle? The left ventricle has started looking like that banana shaped heart which you study very characteristically, which I will tell you in a while as well. So if you read this once again, what happens? See, this is the problem, that the left ventricle has become very, very narrow, very, very patla, very narrow, and left ventricle had to give blood to the rest of the body. Left ventricle had to give blood to the aorta. That is now going to undergo an obstruction. Aorta is not going to get good amount of blood. That is why it's known as hypertrophic obstructive cardiomyopathy. That is one question. And because of that, the body is not getting the demand. This person went to play basketball, football, cricket, or some marathon. He did not get the blood supply that his body demanded, and then the patient landed up in ventricular fibrillation, which is also a question that you get in medicine, which you will study for sure after this in the medicine LRR. Now, when we did a resuscitation and the patient was hospitalized, we got a history that the father died suddenly at the age of 38, which tells me that hypertrophic cardiomyopathy is an autosomal dominant disorder. They will always give you father, brother, mother, someone dying at a very young age. Then they did an echocardiograph, and then they found a left ventricular hypertrophy, small slit-like chamber which is banana-shaped heart, interventricular septum is thickened, which again is marked over here, and 5 years later the patient expires, so at the age of probably 24, which is again a very young age. Now when they ask you, it is again hypertrophic, and most of you had told me that yes, the photo here is ma'am all haphazard, जैसा अभी हमारा syllabus चल रहा है, one thing is going here, one is here, one fiber here, one fiber here. So this is, as all of you told me, helter-skelter appearance. It's not in line, not in parallel, not in sync. It's our life right now during preparation. It's all helter-skelter appearance. Perfect. So now if I had to ask you another question, because I know one question comes and they mix and match every possible thing. Which genetic defect is associated with HOCM? Like I told you, it is myosin heavy chain, but be very certain that you are marking the beta myosin heavy chain. See, that is also how the examiner is going to play with you. Sometimes you know the answer and he particularly asks you which myosin heavy chain. So that is very important. But now you will tell me, what is this written? Titin gene mutation causes which kind of cardiomyopathy? It causes Dilated cardiomyopathy. So now you're going to take exactly 5 seconds of your life and you are going to make an entire list of whatever I have taught you, all the cardiomyopathies. Till here it's for all students, and the last one is only for INI-CET. I give you 2 minutes. Today we are working in time boxes. I have so much to teach you that I have made my timetable before coming. I know that in the first 15-20 minutes I have to finish cardiac, then I have to go to blood vessel. So if I don't work in that time box, my course will go on forever. Same I want you to study. I'm giving you a target of 3 minutes. Finish off this slide with me. So now the most common cardiomyopathy, okay, but what is the most common cause of dilated cardiomyopathy? That's not alcohol. The most common cause is idiopathic, because more than 50% cases we don't know the reason. Yeah, agar idiopathic nahi hai in the options, then the most common cause, as all of you are saying, is going to be alcohol. But if they ask you the most common gene mutation, that is going to be the titin gene mutation. Dilated cardiomyopathy on microscopically, I think you've already told me, it shows us the classical ninja star appearance, and this is the only picture on the internet that they can give, because this is the only one available. So they will show you these cardiac fibers and their nuclei have started looking like a ninja, and that is associated with anything. I mean, a lot of books say that ninja star nucleus means only titin mutation. Ninja star nucleus could mean anything. It is a common finding seen in any dilated cardiomyopathy. How we have learnt is that DCM is to do with alcohol, and alcohol, after alcohol consumption, everyone believes or starts to believe that they are ninjas. So that is how you learn the first thing. Now let's move on to the second one. In dilated cardiomyopathy, the entire heart got dilated, all atria, all ventricles, all 4 chambers. But when I talk about Charcot-Marie cardiomyopathy, it is only and only the left ventricle that is going to get dilated. The reason for that left ventricle dilation is so much stress. But guys, we are not talking about this exam ka chota mota stress that you think is the end of the world. Neither are we talking about those everyday breakups that you keep going through. We are talking about real life stress over here. So the history will either be a family dispute or a property dispute, because in India they love to give you that kind of stress. Or secondly, it will be the death of a loved one. So mostly it is a lady who has recently lost her husband, and that is the kind of stress they are talking about, and that results in increase in catecholamines. Agar thoda sa, yes, all of you are right that ma'am, because they are talking about stress, I mean, what I've not written, it is known as a heartbreak. It is a broken heart syndrome also. So Charcot-Marie means only left ventricle dilated, stress, broken heart, reason, catecholamines. This is done. Now I move on to maybe a question which is very closely associated with it. In Charcot-Marie cardiomyopathy, which chamber of the heart commonly experiences the problem due to presence of maximal catecholamine receptors? I just told you right now, it is going to be the left ventricle which is going to bear the brunt of it. Reason is already written in the question. Catecholamines to increased for the entire body. Now why is it that the left ventricle is getting dilated? Because left ventricle is going to have the maximum catecholamine receptors. Maximum activity of catecholamine happens here, and thus Charcot-Marie is going to occur here. Very good. You're great going, guys. Third one, hypertrophic. Ma'am, you just told that. Rearrange the same. Beta myosin, either you write it like this or you write it as beta MHC. Either way is myosin heavy chain. Then you told us father, mother, brother, someone will have it. So it is autosomal dominant. Then you also told us, ma'am, that this is also known as hypertrophic obstructive cardiomyopathy. So some obstruction will be mentioned because the blood supply is not going properly. Why? Because grossly it is going to start showing you the banana shaped heart. I've got you the real photo of banana shaped heart. You can, the same photo in rapid revision, same in main video, same in GT, same in the exam. And that is the lumen of the left ventricle is going to look exactly like this, and that is going to be the banana shaped heart. Again, the left ventricle is going to look like this. If I move forward microscopically, right now you told me helter skelter appearance, jaisa hamara life वैसा इसका fibers, it is going to go all here and there, and finally the patient is going to land up most commonly in what? In ventricular fibrillation. Last cardiomyopathy, that is restrictive cardiomyopathy. Heart is restricted. Now you answer 2 questions for me. Number 1, restriction of what? Systole or diastole? Is the heart not able to contract or not able to relax? It is more of a diastolic dysfunction. Not able to relax. Why? When will you not be able to relax? If some relative, irritating relative comes and sits in your house and keeps questioning you, when will your exam get over? When will you get married? When will you start earning? Then you will never be able to relax. So same has happened. Some very irritating person has gone and sat in the heart, and mostly that person is going to be amyloid. So be very, very certain, guys, that in the heart, if they ever give me one stain positive, what is that stain for amyloid? Congo red positive, which we will study tomorrow. Why have I made an apple here? Because Congo red to amyloid gives you apple green birefringence, which I will teach you tomorrow also. So please note that Congo red in the heart, I will always think of which cardiomyopathy. Congo red will remind me of amyloid, and amyloid sitting in the heart means no relaxation. Restrictive cardiomyopathy, perfect. And that's the question that I am expecting, that if there is Congo red positivity in the heart, think of restrictive cardiomyopathy. Now for FMG students, the next cardiomyopathy is not important. So a quick water break for you guys while I address NEET PG INI students. There's another one cardiomyopathy which is known as arrhythmogenic right ventricular cardiomyopathy. So commonly sense tells me patient will have arrhythmias. It is a cardiomyopathy, but which ventricle does it involve? Right ventricle. So they will ask you कि क्या होगा right ventricle में? Right ventricle tends to show you fat deposition. They will always give you a question. Listen very carefully, because I'm going to ask you a question after this, an MCQ. So it is going to be fat in the right ventricle. That is why, ma'am, arrhythmogenic right ventricular cardiomyopathy. But now I'll give you a syndrome. Any syndrome? Very good. I started getting answers. Naxos syndrome. I don't know how many times have you guys revised, but it's on your fingertips. I mean, if even in your sleep I would have asked you this LRR, you would have been answering then also. Fat deposition is arrhythmogenic right ventricular cardiomyopathy. Apart from that, if I add two things, if I say that the child also has woolly hair and the child has hyperkeratosis, usually this hyperkeratosis is of the palms and the soles. So it's already the skin is very thick on the palms and the soles. Now the hyperkeratosis is going to make it more and more thick. Now this is referred to as Naxos syndrome. Tell me the defect also. Itna easy se nahi chalega. Naxos syndrome is a plakoglobin defect. Question number 1. And question number 2, it is going to be autosomal dominant. Every word that I have written over here is a question. And I hope genuinely the FMG students didn't go away for a break, because I want you all to answer one question. You have to tell me all the statements mentioned over here that are diagnosis of a patient of ARVCM, and which statement about this condition is true. So it is autosomal recessive. Is that true? Right now, ma'am, you made us write it is autosomal dominant. Is it associated with Naxos syndrome? Yes. Will there be fatty infiltration within the ventricle, to be very precise? Right ventricle, yeah, that is also correct. And does it show mutation of plakoglobin? So, ma'am, plakoglobin right now, yes, Naxos syndrome at least is going to be associated with plakoglobin. So, tell me which of them are true statements. Easy would have been 2, 3 and 4. And all exam students, this is the new pattern. Two questions which are on the rise. One is multiple. 1 and 2 are correct, 2 and 4 are correct. Aise wala questions. Second, match the following. May God be with you in these kind of questions, because over here you have to be very thorough with every line. And where you get a lot of help is match the following. Pray to God that you get maximum match the following, because two options also, if you know, you can do something with the other two and make a good guess. But over here you need to be very thorough. But just in case you don't, you will always get options 1 and 2 are correct, 2 and 4 are correct, 2, 3, 4 are correct. So at least pick out first, make your answer. What do you feel? If you get the same answer over here, then you mark it. If you don't, then start doing a little bit of negotiation. Someone asked me, is desmoglein effect also seen, or desmosome, I think you wanted to ask me. Yes, if you just ask me the defect of arrhythmogenic right ventricular, it is desmosomes. But when you compare it with and you club it into a syndrome called Naxos, a type of desmosome is plakoglobin. So indirectly you are trying to say the same thing. Okay, now we are back. This is your flashcard for the last day, which will help you with everything to do with cardiomyopathy. And I'm moving forward to a question for all exam students. Most likely diagnosis of a 50-year-old woman presenting with fatigue, dyspnea, left atrial enlargement, mitral valve calcification, CT scan showing a large left atrial mass. Left atria, there is only one mass that any student would think of. And ma'am, anyway, when a tumor comes and I can see in the heart, I can see this gelatinous kind of jelly material, myxoid material. It has to be a myxoma. I've got you one final summary of cardiac tumors, but my first question is, which is the most common cardiac malignancy? Have you ever heard a patient having cardiac cancer? I mean, that's hardly very, very rare, especially at an undergrad level. Forget that, even at postgrad level. The most common cardiac malignancy is not of the cardiac, it is of the other organs like breast, lung cancer coming to the heart, metastasis. I think that's very, very good. Now we come to the real tumors in the heart. In the heart, I can see most of benign tumors. tumors, and we always used to write it at Mr. Mr. used to tell me that myxoma is above, so that's occurring at an older age, that is going to occur in adults. Rhabdomyoma is below, so it occurs in children. Myxoma is above, so that is in the left atria. Rhabdomyoma is below, so that is in the left ventricle. Hence, we always write it Mr. Left atria, left ventricle. That is okay. But now you will tell me their cells. Myxoma tends to show you lipidic cells. This is important for NEET and INI-CET. FMG students don't read lipidic cells, okay, never mind. But rhabdomyoma show you the most important cells which you have to know, and that is going to be spider cell. This gets you a lot of questions. Very, very important. You must have seen that. Now I'll tell you certain syndromes. Again, although till earlier I used to tell FMG students not to read cardiac tumors too much, but now in the past 2 exams I have seen questions in NEET and INI-CET, and I think it will get repeated in your exam also. Myxoma is associated with a complex known as the Carnase complex, and there are multiple mutations also with which Carnase complex is associated. One of them is known as the GNAS1 mutation. This is one thing. Second, rhabdomyoma is associated with something called tuberous sclerosis. Tuberous sclerosis is the name suggesting TSC1 and TSC2 gene mutations are going to be there. Please repeat with me. Myxoma is with Carnase complex and rhabdomyoma is going to be with tuberous sclerosis, that is TSC. I know some of you are asking the recent INI-CET question that came that, ma'am, what is the name syndrome and the Lamb syndrome? Should I give this to you for homework or should I make you revise this? I've got a screenshot from the rapid revision also. This time I have included it. Earlier it was only in main videos. This time I have included it in rapid revision also, and that is name and Lamb. Not very easy to learn, but once you read them, I think you will get some some benefit out of it. So if you just had to quickly read what is name and Lamb syndrome, I think I will zoom in for you guys once. Over here, number 1, you can see there are a lot of skin problems. What happens is in the exam you remember name and Lamb, but ma'am, what was with N, what was with A? That is where you have a problem. Firstly, you will see that okay, name and Lamb were to do with myxomas, so at least I need to be very sure that AM has to be atrial myxoma in both places. This much I have to be certain. Plus there are some skin problems, so N is going to be for nevi you know, and moles, nevi or benign nevi. Apart from that, M can also be myxoid neurofibromas, and E can be certain endocrine hyperactivities, and can also be ephelids, which are again coming back to skin. Just read through them once, because in the exam if they write a full form you should know. What is Lamb? Again, L coming back to the skin problem, that is lentigenes, and B coming back to the skin problem, which is blue nevi. So all in all, I realize skin and heart, skin and heart. When everything is related to skin and heart, that is going to be the name and the Lamb syndrome. A quick revision without looking at it. When I talk about nevi, I talk about ephelids, I talk about atrial myxoma, and a little bit of myxoid neurofibromas, that is name syndrome. When I talk about lentigenes and blue nevi, and I talk about atrial myxoma, that is going to be Lamb syndrome. Ek bar padho, and then just kind of, some things you read and you take it with that pinch of salt that I will forget it, and then I will come back to it one day before the exam. This is that kind of a question. Now if I come back and ask you a question, identify the true statements. Can you tell me this? Can you tell me what is this, guys? Yes. Identify the true statement. Is it the most common myxoma, primary tumor of heart in adults? Yes, we always study about myxoma. Is it a malignant neoplasm? Anything with oma cannot be malignant, so this is of course false. Is it associated with GNAS? I just told you 4 things. Carnase complex, GNAS mutation, name syndrome, Lamb syndrome, so this is correct. 90% of these are from ventricle. No ma'am, that is why we wrote Mr. And histologically, is it going to be lipidic cell? So I think I found my answer. Yes, everyone gave me the correct answer. 1, 3 and 5 are going to be correct. Typical exam pattern questions. All of this we've included in version X, because now we know that these are the kind of questions that are coming. Can we move forward, because I'm already running 7 minutes late from my cardiac limit, and that is what I want to teach you, that we also make time slots and time boxes, and we never can finish what we've decided in that duration. But that doesn't mean that I wouldn't have appeared for this LRR. I still appeared. I'm 7 minutes late in completing cardiac, but that's okay. I'll extend the timeline by 7 minutes, but then I will finish finish it. Now I can move on forward. Primary tumor is METs. Okay, but no. The most common primary tumor of the heart in adults, primary. How can METs be primary? METs means something is coming to the heart, right? So primary tumor, Dr. Prachi, has to be from the heart, and from the heart it is going to be myxoma. I hope you've got your doubt cleared. Moving on to, let's go into a little bit of surgery and pathology combination. Let's go into easy questions, ma'am. Jaldi wale 2 minute wale questions. Most likely diagnosis in a 48-year-old man, and I know you all are not reading this. Ma'am, we have been very certain. We saw a nail bed and we saw a lot of tumors written. Nail bed mein hame ek hi aata hai, and that is glomus tumor. But don't be so overconfident. I mean, in the exam, thoda sa pad lena. I agree with you over here that whenever you see something to do with subungual, means to do with the nail, but at the same time, this has to be not painful, exquisitely painful, excruciatingly painful, very, very painful. ऐसा कुछ भी fancy English adjective used for pain, excruciating, exquisite, extensively painful, that is what defines a glomus tumor. And glomus tumor is actually going to arise from a glomus body, and without these two, so is answer is not complete. Now you come down to reading, ma'am. Pathology, is it important? I mean, very few times I tell you don't read pathology. This is where I want to tell you, because glomus tumor for you guys is not diagnosed on pathology. For me it is, but at your level it is not. At your level it is a subungual tumor which is diagnosed on the excruciating pain. That is how you are going to study it. Simple, one line question, khatam. Coming to another one line question. The questions which you don't read on your own, and hence I am making you read them. Cystic hygroma is a manifestation of which vascular tumor? Dr. Jigisha, this LRR is for all exams unless I mention that, okay, this is for INI-CET and you do not listen, then you don't listen for 5 minutes. Till then it is for everyone, and many FMG students will believe, ma'am, ये question हमने नहीं देखा कभी. That is because you guys are probably doing only FMG PYQ. I want you to do 3 years of NEET PG PYQ also. So I have made sure those PYQs are in this session, and then you don't miss out on them otherwise. Very good. Cystic hygroma is cavernous hemangioma. So if I ask you what exactly is a cystic hygroma, it is a lymphangioma. It is a lymphangioma means what? It is going to be a lymphatic channel tumor, right? Lymphatic channels. Usually we focus only on hemangioma, like I also ended up saying hemangioma by mistake. But this is what? This is a lymphatic channel tumor, that is cavernous lymphangioma. Cavernous means the big lymphatic channels will become very big. This is not capillary lymphangioma. They are not small lymphatic channels. They are big lymphatic channels. And the only place where the 3 questions that I've written here are the only 3 questions you get in path, peds and surgery. Cystic hygroma occurs where? It occurs in the neck. What kind of a tumor is it? It is a lymphatic channel tumor, and it is seen in association with Turner syndrome, 45XO, yes, where X chromosome is deleted. 45XO. These are the only 3 questions of cystic hygroma. I think we are done. Dr. Arpit, residency right now, no, it is not coming up, not in the pipeline. Okay, moving on to the next one. Let's see another tumor over here. This is super basic. ये सबको आता है, irrespective of exam. Which of the following substances is not associated with the development of angiosarcoma? Not associated with development. So ma'am, we used to study something to do with, many of you answered A, because angiosarcoma is associated with vinyl chloride, but I asked you what is not associated. This is the mistake that you do in the exam also. You know the answer, but you're in so much of excitement of knowing a topic and that popping up on your screen, that you forget to read is and the, you forget to read not, except, true, false. Please, ye wala na error haunts you for many weeks after the exam. I don't want anything haunting you after that. When I say VAT chemicals, we should know that VAT chemicals are going to go and affect the liver. And what do they cause in the liver? They cause a blood vessel tumor in the liver, that is angiosarcoma of the liver. So what are the VAT chemicals? I will, obviously they are in front of you. You will tell me, how do I get exposed to it? Someone said VAT ne liver ki vaat laga di. Bilkul, very good. So vinyl chloride is what? Polyvinyl chloride, plastics basically. Arsenic comes from where? It comes from pesticides, right? That is why we say wash your food and vegetables and everything very well, because a lot of pesticides contain arsenic. And then thorotrust, I'm sure you have read it in radiology, that once upon a time there was a thorium based contrast dye which was given for radio procedures. Then they got to know that these 3 things are causing angiosarcoma of the liver. Now of course radiology people don't give it, which is obvious. One more thing, I know you know these basic VAT and VAT, Then you also know things like acha, smoking say lung cancer, smoking say oral cancer, alcohol causes liver cancer. I mean, these are very stupid questions. No one's going to ask you such questions, and if they do, I mean, I would love it that you get those marks. But what I think they would want to confuse you in the exam are two things which you study in different subjects but you get confused with. I will now make a table over here in pathology for you. Benzene versus benzidine, I feel, is one question where everyone's messing up. So benzene is known to cause AML and benzidine is known to cause urinary bladder cancer. So please, if you read this in surgery and other places, do not mess up. Benzidine causes bladder cancer and benzene is going to cause AML. I hope you're not messing up here. One more thing, although you know that tobacco causes what? Oral cancer, lung cancer, etc. Examiner knows you've seen all those Mukesh wala advertisements before Bollywood movies. He knows that even non-medicos are aware of what tobacco causes. So the examiner's question will be that is tobacco the single most important risk factor for a kidney tumor, and that is renal cell carcinoma. That's the question that I expect. So either it's a tobacco with RCC, or it's a benzidine, or it's a VAT chemical causing angiosarcoma liver. So that means that tomorrow in general path, this part of it I can skip because I've done this today. Okay, I'm talking about coming back. I'm talking about all the blood vessel tumors. How can I miss out this blood vessel tumor? I have not even given you a question. The buzzword is enough. क्वेश्चन की ज़रूरत ही नहीं मैम. HIV पॉजिटिव पेशेंट विद अ स्किन ट्यूमर, what would you think of? And not just a skin tumor, a red color skin tumor, which means they are talking about a vascular tumor. What is, as I said, some places you don't need questions. Yes guys, great, it is Kaposi sarcoma, but that's not how the question will come. My question is that Kaposi sarcoma is a blood vessel tumor, hence the patient has reddish purplish kind of lesions where on the skin, because what is the most common site of Kaposi sarcoma? It is going to be the skin of where? Of the lower legs or the lower limbs. But if they ask you the second most common site, and that is going to be the lymph node. This is first two derma questions. My microbiology question is going to be, it is associated with human herpes virus 8, which you guys are, my micropatho, so you answer on my face. So it is HHV8, very good. But the recent exam question was that what is its association with the CD4 count, which has led to a lot of confusion, and that I'm here to solve. Kaposi sarcoma is occurring in HIV positive patient, right? So CD4 count is very, very important. And I am quoting directly from all the standard textbooks like Harrison and Robbins and all the journals that Kaposi sarcoma can occur at any CD4 count below 500. At any CD4 count below 500, Kaposi sarcoma can occur. But typically, if you ask, typically it tends to occur below 200. This has always somehow got me screenshots after the the exam, and after they do Q banks, and after whatever session you attend. So I've written it once and for all. In my senses, I am teaching you this. So don't send me screenshots of this again, because this is the final answer. It can occur at any count below 500, but typically it tends to occur when the CD4 count is very, very low, that is below 200. Is that okay? हाँ, very great. CD4 less than 200, Dr. Dhwani is saying, मैम उसमें तो एक और होता था ना, PCP, pneumocystis carinii pneumonia. Very good. But Dr. Dhwani सब कुछ पैथो में पढ़ लिया, तो माइक्रो में what will I come and do? I will have to sit idle, so that I will teach you in micro. But I'm so glad you are able to correlate this. Okay, let's move on to the next question. You are done with all vascular tumors, so I get you a lengthy question, but damn easy. And now before I start with this, students who are answering very well, great guys, but students who are feeling that others are answering so well and I am not, this is another kind of FOMO. So if that live chat is getting on to you, just stop reading everyone's comments. Sometimes it's entertaining, sometimes it's depressing. And if it's depressing you, then you stop reading the live chat, because here you are only here to what? Concentrate on what I am teaching, concentrate on what you have to learn. Do not concentrate on what someone else is answering or not answering. Okay? And students who want to still attempt, do not study, but attempt. Say out wrong answers, chalega, but don't keep quiet and don't feel that, oh, what if I don't know? You make errors and then you will remember it for a longer time. Meanwhile, everyone not listening to my philosophical lecture and said that we will read the question instead. 20-year-old woman in vasculitis. I hope you scanned through the options and knew that kuch to vasculitis hai. Vasculitis mein more than 50 years and less than 50 years years is a game changer, because more than 50 years, when the patient is in giant wala age, then it is a giant cell arthritis. And when the patient is not in the giant wala age, then we most likely go in for Takayasu. I mean, that's what I'm saying. This is just one very crude and brutal way of solving questions. More than 50 giant patient hai, matlab old patient hai, to giant cell. Less than 50 Takayasu, and Takayasu is also referred to as the pulseless disease. So when I read this, did I notice there is absence of a pulse in her right arm? Also, everything is left hand, right hand, means all upper limb related features are there. It has elevated ESR, it has increase in platelet count. Now tell me the third name of Takayasu. So I'll directly show you to what am I reading. I am reading vasculitis. Ma'am, vasculitis, I'll give you a brief, guys. I have exactly 10 minutes or 12 minutes as per my time boxing. I will show you a photo later on. I have a photo today where I have made a timetable like you guys. 10 minutes mein ye padhana hai, 12 minutes mein ye, because otherwise this session will go on for 5 hours, the amount of content I have. So now over here, if I ask you that I will teach you large, medium and small vessel vasculitis, okay? You will tell me the classification. What is the name of this classification on the basis of which this is done? This is the Chapel Hill classification. Basic nahi bhulna. Under large vessel vasculitis, ma'am, you have T and T, temporal and Takayasu. Right now you're teaching us Takayasu, and you said that in Takayasu the age will be less than 50, and in giant cell arthritis the age will be more than 50, and that is actually the most common vasculitis that you see in adults. Right now, Takayasu less than 50, number one. There is pulseless disease because upper limb pulse nahi mila. The third is aortoarthritis, because over here I can see the radiology of arch of aorta given, in which I can notice that the vessels have become very narrow. Narrow ho gaya to obviously na blood supply nahi hoga. So which is the most common vessel affected? It is subclavian artery. Right? It is subclavian artery. Very good. Subclavian artery. Where does it supply? The upper part of the body. So if subclavian artery is becoming narrow, then the upper part of the body is affected. So that is an upper limb absence. That is upper limb pulse absence that is happening. These days they are sick of these kind of most common questions. They started asking you the least common wale questions. So least common wale questions are going to be for Takayasu is the coronary artery, which could be asked. And I know all our focus always goes on most common and we tend to ignore least common, but they started asking you these questions. So can I say it's the aorta that is affected, branches of the aorta that is affected? And when I come back to this question, they said there is narrowing and occlusion of the branching arteries, including the subclavian artery. There is also heart failure, dies of pulmonary edema, the aorta is involved and has a thickened wall. Everything is going for Takayasu, and that is exactly what I'm going to match. If I just had to ask you one word, buzzword of every vasculitis, for polyarthritis nodosa, which virus would have been affecting? Hepatitis B virus should have been there. Hepatitis B surface antigen. K for Kawasaki, ma'am, K for kids. There would have been a history of a 4-year-old kid, and how can we forget that strawberry tongue that they would ask me for? And Burgers, B for Burgers, B for BD. So there will be not just BD, but any kind of smoking history would be given. I've always told students, you know buzzwords of every vasculitis and you are so easily able to solve. For Takayasu, you know it is going to be the pulseless disease. Moving on to another question. Which of the following, I'm in the same large vessel vasculitis, which of the following statements regarding giant cell arthritis is true? The only true statement is asked. Is it going to show you granulomas? I think it does, because giant cell word means granuloma, to wo to dikhega. Is it most commonly involved artery is abdominal aorta? If anyone knows the full form or the other name of giant cell is temporal arthritis, then it has to be temporal artery, not abdominal aorta. Is there continuous nature of involvement? No, because when you look at this photo and this female over here, you will notice that the temporal artery is having nodules. It is not a continuous involvement, it's a nodular involvement, not continuous, nodular. And does it involve small vessels? Ma'am, again and again you're saying it's large vessel vasculitis. Only correct statement. This question is from the previous LRR. So as I'm telling you, all previous LRRs I have clubbed into it, plus I have added version X extra questions. So end mein sirf chahe 10 minutes hame zyada lag jayenge, but this is the only LRR that you have to see. Now coming and solving all questions, you have exactly 30 seconds to finish off giant cell arthritis. Are you ready for this challenge? Giant cell arthritis, ma'am, you told us it's seen in giant people. It is seen in over 50 years of age, and wherever you will see giant cells, you will always see granulomas. This the word tells me. Apart from that, temporal arthritis. So what is the most common vessel affected? Very good. Superficial temporal artery. Superficial and temporal artery, matlab most common symptom is headache. Not just headache, but throbbing headache. Lots of and but localized. जहाँ जहाँ temporal artery का problem, वहाँ headache. Which is the most specific symptom? That is going to be jaw claudication or jaw pain. Specific पूछा. But what is the most dangerous symptom? Blindness, loss of vision. That is most dangerous, and hence I get to know that the treatment has to be steroids, but the treatment has to be steroids stat or steroids ASAP. Don't wait for the report. Kya pata you were waiting for this granuloma report and meanwhile the patient had blindness and then now that is irreversible. So you're in for a big trouble. So start steroids even without the report in hand is how you get a question. If you are clinically thinking of giant cell temporal arteritis, will you next step of action? Will you wait for report or will you start steroids irrespective of report? So start steroids is going to be the answer. Very good, due to ischemia. Amazing, guys. That's so nice. So your large vessel vasculitis is done. If I ask you the next question over here, let's see if you can answer this. There is a 39-year-old female who presented with complaints of headache, fever, and there is pain in the upper extremities for 3 weeks. She is admitted to the ward with clinical suspicion of some autoimmune vasculitis. Arteriography is going to reveal involvement of the thoracic aorta, and which is the most likely suspected in this patient. So over here, who said that if I finish the topic, I can't ask you the question again? I can ask you anything as per my choice. If it would have been a smoker, I would have thought of BD Burgers. No. HSP, I will teach you in a while, occurs in kids. This is not in kids. Firstly, 39-year-old, not a case. Sturge-Strauss syndrome also I will teach you in a while. It shows you increase in eosinophils, not mentioned. Classical Takayasu, because look again, which involvement is there? Upper limbs involvement is there. And what is aortoarteritis? Ma'am, it involves the aorta. Everything is mentioned over here for Takayasu. Done with it. Now I've got you a question which is from the new type of questions which we are getting, slightly lengthier, but they're talking about the same diseases. Here you have a 52-year-old woman who presents with a 3-month history of muscle ache, joint ache, numbness in hands and the feet, blood in the stool, multiple organ, muscle, joint, stool, so many things. Experiencing episodes of abdominal pain and nausea. Physical examination shows decreased sensation in the extremities, decreased peripheral pulses. Lab investigation shows increased ESR and CRP. Peripheral neuropathy is also there. What is the most likely diagnosis? I'm getting answers of Takayasu because all of you probably believe that there is a lot of upper limb involvement, but with that upper limb involvement there is also decreased sensation in the distal extremities. Also you can see something called blood in the stools. Also you can see muscle aches and joint aches, and that is not something which is going in favor from Takayasu. Now I started getting the right answer, polyarteritis. I just want to tell you, the name only tells you polyarteritis. When every system of the body is getting affected and you can't pinpoint कि अच्छा इस system में problem है, that is polyarteritis nodosa. But when you remember which is the system not affected, P is not for peak is the most famous mnemonic that we have, which means that these patients are going to not involve pulmonary vessels. Polyarteritis does not involve pulmonary vessel, but it involves everything else, and that is why this patient had involvement of everything but not pulmonary system. So when I'm talking about polyarteritis nodosa, now you need to know that PAN having 3 alphabets will show me what? Will show me fibrinoid necrosis. So I can see a blood vessel over here and I can see that pink color fibrinoid necrosis. Now they will ask you what is polyarteritis nodosa associated with? Ma'am, that is hepatitis B. They don't write hepatitis B in the exam. Either they write the antigen. Which antigen of hepatitis B? Surface antigen. They don't even write surface antigen. What is the other name of surface antigen, guys? It is going to be the Australia antigen positivity that you have to know, and this is how the question will be there. Same question, same photo. You'll make a diagnosis of PAN and the answer will be Australia antigen. Please watch out. Sometimes you know the answer and still you're messing up, is not cool. Okay, one more thing. This is only 30-second break for everyone else. INI-CET students, Australia antigen or HBS antigen, whatever you want to call it, there is a special stain for it which is known as the Orsin Shikata stain that can be asked. I've taught you in the main videos. In case you skipped it, for INI-CET it is important. Now come back, everyone else. When I'm talking about polyarteritis nodosa, you said it's a medium vessel, and who forgets this very famous mnemonic of pathology called Pan Khata Bachcha, right? So Pan Khata Bachcha tells me Pan is Pan. Pan has 5 questions, you will answer all. Question number 1 you have answered. It is associated with viral marker hepatitis B Australia antigen. Question number 2 you have answered, it will cause fibrinoid necrosis. Question number 3, polyarteritis, many arteries. Which is the most common? Very good, most most common is renal. Ma'am, our problem is we think renal involvement matlab nephrotic syndrome and nephritic syndrome, but move out of the world of those syndromes. Does polyarteritis nodosa cause glomerulonephritis? It doesn't. See, it affects the renal vessel, but it doesn't cause glomerulonephritis. So now my question is, what does it cause? In the kidney, I'm drawing a photo, you will tell me, what does polyarteritis nodosa cause? It causes the very famous flea-bitten kidney. There are so many causes of flea-bitten kidney. Today I'm going to give you 2-3 things for you to type out in the comments later on when you view the video, and one is going to be flea-bitten kidney, and there is a mnemonic which we study called We Hate PSM. We've just started today and we will complete it tomorrow. So in case you get time, type it, and I will also type it and pin the comment. That's the causes of flea-bitten kidney, but I want you to type it, otherwise I don't know it. I want you also to know it. Anyway, coming back, flea-bitten kidney, one of the causes is going to be polyarteritis nodosa. Most common vessel, renal. Glomerulonephritis does not occur, becomes question 4. Which is the vessel never ever affected? Pulmonary is spared. So P is not for P is how you're going to learn it. Now coming to pan, khata, bacha. Pan is done. Khata, this last year exam, Kawasaki, they went obsessed with it, guys. Number one, Kawasaki obviously is to do with kids, and I've not got your question because I'm going to mark every question over here. Kids means they will give you some kid who is less than, let's say, 5 years of age, and now they start saying that that kid has an increase in the platelet count. It's not written like that. Platelet count matlab thrombocyte. So when platelet count is increased, they write it thrombocytosis. You feel acha, it's some hematological problem, but then they come back and show you such pictures, and that's Kawasaki. So what's the criteria for Kawasaki? Number one, fever. Fever is like a mandatory criteria. It has to be there. Okay, after that you have cream criteria, and out of these 5, at least 4 should be present to call it this Kawasaki. So what is the question now? What is C? C stands for conjunctivitis. You know, the question in the last exam was, what kind of conjunctivitis, purulent or non-purulent? So you know that this is not a bacterial infection, this is a blood vessel problem. So it is a non-purulent conjunctivitis. That was a previous year question. R is going to be for rash. E for edema, so they will say that the child is swollen, edematous. Next MCQ came as A for adenopathy. Can you tell me, where are the lymphadenopathy seen? Where is lymph node enlarged? It is the question that they asked you in the next exam. It is going to be enlarged in the unilateral cervical region. So it is probably going to be only one side of the neck, and that is going to show you these enlarged cervical lymph nodes. So unilateral cervical enlargement is asked. So remember, the conjunctivitis is bilateral, non-purulent, and the lymphadenopathy is going to be unilateral and it is cervical. Of course, M is mucosal. I mean, no points for guessing. It is going to be the strawberry tongue, and so many people already know that strawberry tongue is seen in 2 conditions. Chota chota we will write. One is going to be Kawasaki, another one is scarlet fever. We all know this. I'm writing it only for completion of LRR. Pata hai humko. Scarlet fever we will study. Streptococcus we have to study. One rash. Ek cheez batate jao, and then when the right time comes, I will teach you scarlet fever. There's one very famous rash. There's a 10-second lag till the time you write. I'm asking you the next question also. Latest question. Which antibody is causing Kawasaki disease? Sandpaper rash of scarlet fever. Very good, guys. That answer I have got. Sandpaper rash and scarlet fever. Antibody kaun sa hai that causes Kawasaki disease? Anti-endothelial cell antibodies. Anti-endothelial cell antibody is the latest question that I expect. Now moving forward, pan, khata, bacha, B for burgers and B for BD smoking. What if someone says, no, I have never touched a single cigarette or BD in my life, and still I am having burgers? Can it be associated with HLA polymorphism? Yes, it is associated with HLA B5, A9. These are some numbers for INI-CET that are important. Just giving you some 2 very, very important HLA which are important for INI-CET that I expect. Ek to HLA B5 and A9 which are important for burgers. One HLA polymorphism which is for every exam is going to be the one in that gluten wala disease. Celiac disease ka HLA bata do, which is very important over here. And then other HLAs I will teach you eventually. HLA DQ2 and DQ8. These two somehow in the recent exams have become very, very important, trending, whatever you may want to call it. In pe question zyada aane ke chances, especially this celiac disease ka DQ2, DQ8, they are super obsessed with it. Coming back, last to last exam, FMG students, there were 2 questions which were in the same exam from burgers. Number 1, there was a history of BD smoking, everyone marked burgers. In the other question, they asked you the other name of burgers, and burgers is known as TAO. Thrombo means kya hoga? Blood clot. Angitis, itis means inflammation, and obliterance, the blood vessel will be obliterated. So this is going to be what? Number 1, ma'am, the blood vessel has inflammation, the blood vessel has blood clot, and the blood vessel is going to be obliterated. Only blood vessel? Yes. So when I say blood vessel, what all comes in your mind? Artery mein hoga? Yes. Vein mein hoga? Yes. So patient of course will have pain, but till the time artery and vein are affected, this kind of pain is going to be the intermittent pain. He goes for a walk, then he has pain. He goes jogging, then he has pain. He climbs 4 flight of stairs, then he has pain. Thoda sa yoga kara, exercise kara, then he has pain. But when the nerves are affected, there is going to be pain which is going to be at rest. That is when I say nerves are also affected. But what is never affected? Never affected is going to be the lymphatics, and that has been a previous year question which I would ask you, but I have already told you, so I'm not going to ask you. So that's why I said for this slide I've not gone the MCQ way. I've gone the enumerating all the MCQs to you, because iske baad there is no other question that comes up. Very good. Dr. Pooja says, ma'am, the treatment is the first important treatment of Burgers is to stop smoking, and then you have to give symptomatic relief to the patient. Everything is important over here. Jaldi se getting you to answer one quick question that they could ask out of this, which is already there, lymphatics wala. Moving on to the next question. I hope I can zoom out now. Let's start reading my favorite question. I don't complete any LRR without it. Okay, so there's a 6-year-old girl presents with a 2-week history of a skin rash over her buttocks and legs and joint pain. Ma'am, हमें भी आपका favorite question पता है. Okay, there is, everyone's answered it. Someone said PSGN. Okay, that's very acceptable to an extent, because you are seeing a child. PSGN occurs in a pediatric population, and you are seeing a child with somewhat like a cola color urine, which is kind of making sense to me also. But you have to look at the entire question, right? And what other things this child is suffering from. Also be rest assured that in PSGN, IgA is not the antibody that is getting deposited. So that is contradicting this. Also the other questions are contradicting it. It is going to be a case of Hinox-Schönlein purpura, which I call as Hinox-Schönlein parpura, because we are going to study it in a little bit of a Bengali accent. Number 1, this is a vasculitis which is seen in kids, and hence the age was going well. Now, one of the A's that we have over here is that it is due to one antibody, that is IgA, which is going well with the question, that is IgA deposited in the wall of the small blood vessels. Now, what are the organs affected? P is going to be purpura. When I say purpura, it is palpable purpura, and this palpable purpura is usually below the buttocks and the lower limbs, which is going so well with the question over here. Next is going to be abdominal pain. That was not mentioned in this question, ma'am, but over here they said that this patient is going to have something called as a test. Stool Guaiac test is positive, guys. Guaiac test is done for what? I mean, I shouldn't be saying such things online, but never mind, anything to teach you guys. Guaiac test will always remind you that it is done on which particular sample, urine or blood or stool or sputum or CSF. So now you will always remember it is done on a stool sample. That is pretty obvious. But what are you wanting to study over here is occult blood loss. You know, sometimes when you ask a patient that are you seeing any blood in your stool sample, he will say no, every morning when I go to clear my stomach, I don't see any blood in the stool sample. He will come and give you a stool sample, you will also not see any blood in it, but there is still little amount of blood in it which is not visible to your eyes. But when you will do a clinical test, you will find blood, because that is such little blood loss that is happening. So abdominal involvement is definitely there, because occult blood loss has come out to be positive in this person. Apart from that, A for arthralgia. Yes, this kid also had joint pains. And lastly, there is R for renal involvement, which again there is such a nice renal history mentioned over here with RBC, hematuria, and in fact please note renal is the most common involvement that you see in the entire Hinox-Schönlein purpura. This is so classical. But you guys are going to tell me one more question. ये थोड़ा medicine वाला I'm asking you. In Hinox-Schönlein purpura, you are saying palpable purpura है. Means palpable from a dermatology point of view, sign eliciting point of view. Where do you see non-palpable purpura? When the platelet count goes down. Because we know that in Hinox-Schönlein purpura, the platelet count is totally normal. But in ITP, when the platelet count goes down, that can result in non-palpable purpura. And where do you see pinch purpura? Which means that when you pinch, वैसे तो the skin is normal to look at, but if I pinch the patient, then redness will happen over here. Pinch होने पे purpura, and that is going to be amyloidosis. That is going to be amyloidosis. So that causes pinch purpura, because you know, simple, tomorrow I will teach you, when amyloid goes into our blood vessels, the blood vessels become very weak. So if I pinch such a patient, his blood vessels will be so weak that on me pinching, the blood vessel will break, and as soon as I will leave the skin, that broken blood vessel will look very, very red. So that is what you call as a pinch purpura. Very, very good. Amazing. You know, there are some miscellaneous answers also, like I said, ITP students are telling me antibodies, and trust me, I'm reading them. I'm not responding to each one of them, but I'm reading them, and you're correct, and that is why I'm not responding. In case I find any gross error, I would correct you out there, but it's so nice to see that you're able to link anything from anywhere with another subject and correctly, which is so nice. Okay, now asking a doubt over here, Dr. Khushi Singh ma'am, is Henoch-Schönlein purpura related with IgA? So is it associated with the IgA nephropathy? Dr. Khushi, they are said to be parts of the same disease, in the sense that if only renal involvement would have occurred because of IgA, I would have called it IgA nephropathy. But if along with renal, all the other organs are getting involved, now I want to call it Henoch-Schönlein purpura. So are they like two ends of the same disease? In a way, yes. Are both mediated by IgA? In a way, yes. So you can say that. Moving on to the next question. Is a 59-year-old male patient admitted to the ward with complaints of fever, joint pain, weakness, cough and dyspnea, multiple organ again. During examination, the nurse noticed blood in the sputum. So two organs. One is of course going to be, I can classically see a lot of respiratory involvement. So first they started off with chest x-ray, and they found bilateral infiltrate. They did a biopsy which showed granulomatous inflammation with multinucleated giant cell. Honestly, in our country, first thing I would have thought of would have been TB. But when we went forward, a diagnosis of Wegener's was made. I wish I would have read this line first. And then they would have asked me which organs are the most commonly involved in Wegener's. It is option B, ma'am, over here. So this is the last vasculitis question that I have. And that is why I tell you, retrospective approach karna hai, but you have to waste only 2-3 seconds. Doesn't mean you start reading the entire option ulta. You read quickly. Acha, okay, they've asked me some organ question, and last 2-3 lines have something called Wegener's. At least I know, acha, it's a pathomedicine question, it's a vasculitis question. Now let me start reading. Vasculitis question, but their entire emphasis is on lungs. So this is probably a case of Wegener's granulomatosis, because Wegener's granulomatosis shows a granuloma, as you can see over here, and that shows granuloma in blood vessel because it's a vasculitis. But which two other organs? In the lungs and in the kidney. That is why the lungs were affected, as you could see over here. Everyone has started saying C ANCA. उससे पहले एक और triad. One triad is that there are a lot of granulomas in the blood vessel, in the lungs, in the kidney. But there's one more triad called as the ENT triad. ENT triad means that there is of course ears. So ears में क्या होता है? Patient has otitis media. Then there is going to be nose. Nose में there is nasal septal perforation. And then the throat. Instead of throat, we have come to gums. So strawberry gums are seen in Wegener's granulomatosis. And everyone is meanwhile, you know, someone else outsider reads our chat, he'll be like, ये क्या बात करते रहते हैं, पान खाता बच्चा, World Cup. Now everyone has started writing World Cup, which happens to be all internal jokes, internal mnemonics, because only we as medicos can understand the language that we are talking in. Antibodies. Antibodies are of two types. This is not just C ANCA, P ANCA. Pura revision karna hai abhi ke abhi. There are two antibodies, ma'am. One is C ANCA, one is P ANCA. The story with C ANCA is so simple because there is only one disease, and P ANCA is like a dustbin. You have put everything into P ANCA. But let me start. When they ask you this Wegener's granulomatosis, that is going to show you both. It will show you the C ANCA also and P ANCA also, but select one in the exam. Wegener's shows you both, but you said World Cup. So okay, for Wegener's, C ANCA is going to be more common than P ANCA. I am just going by what you are telling me. You are teaching me today. After Wegener's in C ANCA, now the entire world is in P ANCA. Wegener's is also in P ANCA, microscopic polyangiitis P ANCA, Churg-Strauss syndrome P ANCA. Not just vasculitis, ma'am. दूसरे chapters. What is UC? Ulcerative colitis. Ulcerative colitis is also P ANCA. And one disease of the liver, primary sclerosing cholangitis, that is also P ANCA. P ANCA is like real material dustbin, सब कुछ P ANCA. Only thing for C ANCA is Wegener's World Cup. Now they don't ask you. इतनी मुश्किल से we learnt it. They don't write C ANCA, P ANCA antibodies in the exam. They are going to add other names. So we learn it when ma'am already by this list I was half dead. Now to revive me, you will have to give me a CPR, ma'am, to make me learn new mnemonics. C ANCA is also known as PR3 ANCA, and hence I've given that CPR. So C ANCA is known as PR3 ANCA, and P ANCA is known as MPO ANCA, which is done, which is great. I think all of you are settled over here. Yes, all good. Now someone asked me how to differentiate Wegener's and good pasture. Antibodies are so important. That is exactly what we are discussing. See, you are right that good pasture will also involve lung and kidney. In good pasture, there is bleeding from the lungs, so hemoptysis, and bleeding from the kidney, hematuria. But in good pasture, there are antibodies against the collagen type 4. Right, and that is a kind of RPGN type 1, which I will teach you in a while. So usme to immunofluorescence will be given, so many other things will be given. Over here the antibody mentioned is C ANCA, P ANCA. Over there the antibody will be collagen type 4. Okay, someone said MPO is myeloperoxidase. Yeah, MPO is myeloperoxidase, and Dhanushri Singh is ulcerative colitis, P ANCA. Ha, pakka, 100% ulcerative colitis is P ANCA positive. Okay, now moving on forward, I've got the answer, but now I know you guys know this. I've made a list for you. मुझे सारे strawberries ऐसे I want to take a break. I want to put it on you. Tell me all the strawberries and then I'll show you the list. Where do you see strawberry tongue, which I just showed you a while ago, that is seen in Kawasaki disease and scarlet fever? This you've told me. Where do you see strawberry gums? It is seen in granulomatosis Wegener's. This you've told me. Where do you see strawberry cervix, which you have read in Gynae LRR? Otherwise also you knew. It is seen in Trichomonas vaginalis. I've written this as a flashcard. Abhi I'm taking your test. Strawberry cervix, Trichomonas vaginalis. After this you will do surgery LRR. Strawberry gallbladder. Ma'am, when in the gallbladder there's a lot of cholesterol. Cholesterolosis of the gallbladder is going to show you the strawberry gallbladder. Where do you see micro, my subject? The polyps that are coming out from the nose, they are strawberry polyps. So nose matlab ma'am rhino sporidiosis shows you strawberry polyps. And one last, on radiology, where do we see the strawberry skull? So strawberry skull on an, of course, on radiology appearance is seen with Edward syndrome. बच्चे का जो head होता है, that head, obviously the back side of the head, occipital of the head is very, very big, and then the chin is a tiny little chin like this. So this is a strawberry skull that you see in Edward syndrome. Whatever we discussed is written in the PDF. So I want you to interact more with me. Writing ka tension matlo, that I've taken care of. These are all the strawberries and listed for you. Can we move on away from the world of vasculitis, because we are pretty much sick of it, and we move on next to a 24-year-old female presents to the outpatient department due to a cough and respiratory difficulty for 4 months. The cough occurs mostly at night or early morning, and physical examination is unremarkable. Cytological examination of her sputum shows the following finding. There is something that has been shown over here which is in the sputum, and you have the 4 options in front of you. What finding was it did you guys selected? I can see some needle-like crystals. I mean, I just want to go through it. If you have a case of pulmonary fibrosis, sputum is not something that is anyway going to be produced only in most cases, and that's a diagnosis of exclusion. First diagnosis bhi nahi hoga. When I talk about emphysema patients are going to come to me with definitely a history of smoking is going to be there, which is not mentioned over here, plus sputum examination not a mainstay for diagnosis. Talking about bronchiectasis, yes, sputum can be there, but I want to ask you, is the investigation of choice for bronchiectasis a sputum examination, or the investigation of choice is going to be the HRCT? Ma'am, we know that. And HRCT mein what appearance do you see in bronchiectasis? We see the tram track appearance and the signet ring appearance. All this I am telling you from other subject point of view. So yahan par even by ruling out asthma was well. And yes, these needle shaped crystals are what? These are known as the Charcot Leyden crystals. You can see this. What are? I've got you the 3 C's. Asthma shows you 3 C's in the sputum. You've written it. I'm going to take 30 seconds to finish it off. Asthma shows you Charcot Leyden crystal. What is it made up of? It is made up of galactin 10. क्या होता है galactin 10? Galactin 10 is something that will come from the eosinophils, which tells me eosinophil to can go up in any kind of parasitic infection also. Eosinophil can go up in any kind of allergy also. So ma'am, any allergy, Even if it is not asthma, some other allergy, can that also because of eosinophils show galactine-10 and show Charcot-Leyden crystal? Yes. If it's a parasitic infection, eosinophil badhega, can that show galactine-10 and Charcot-Leyden crystal? Yes. In fact, later on, I'll give you an example, 2-3 days later when we come to microbio LRR, over there, we will talk about everyone's favorite parasitology. We will talk about Entamoeba histolytica. Patient will have diarrhea. You will say in the diarrhea sample, Charcot-Leyden crystals are there. अब डायरिया सैंपल में तो एस्थमा नहीं बना के आओगे ना, ऑब्वियसली डायरिया सैंपल में Charcot-Leyden crystals, you will say, oh, there must be some parasitic infection, maybe it is Entamoeba histolytica. If they are talking about the sputum showing you Charcot-Leyden crystal, this could be a case of allergy. Interleukin 5 association, wherever there is eosinophil, कोई doubt नहीं, E for eosinophil, E, 1 A B C D E, fifth alphabet, it is always associated with interleukin 5. That concept goes forever. Moving on, the next C that you see in asthma, coming back to asthma, is cereola bodies. Cereola bodies are basically lot of these epithelial cells. See, when someone is coughing, you cough with a lot of pressure. So all the airway epithelial cells, they are also going to come out. So cereola bodies are made up of airway epithelial cells. Lastly, the name only tells you Kirschmann spiral, that is made up of mucus, mucin. That is why these patients have sputum, balgam wali khansi, that is sputum cough, productive cough. So the 3 C's of asthma are pretty much in front of you, and there is something that is done. Before I go on, there's one question which has come after a while, but I would want to address it. Dr. Himanshu is asking, is there any other name of Wegener's granulomatosis? Yeah, Dr. Himanshu, now I've taught you in the rapid revision also. Wegener's granulomatosis में से ना Wegener's word हटा दिया है because they said it's not adding any knowledge in our life. Now they call it granulomatosis with polyangiitis because now they feel this word is at least giving me some information that granuloma दिखेगा and many blood vessels are affected. So granulomatosis with polyangiitis is what is going to be there. Is that okay? Done? Okay, let's move forward. Now, after this Charcot-Leyden, cereola body and the Kirschmann spiral, I move on to see what did you notice over here? Very needle-like. Lung mein na, there are these two line wala things that can come. I am talking not like a pathologist. I am talking like that second year student who makes some tricks to identify slides. ये पिंक है, ये लाइन है, ये गोल है, that kind of student I'm talking like. Exactly how I know you guys study pathology. So when you see in the lungs something in sputum and these kind of crystals, you will say, acha, this is Charcot-Leyden crystals, that is done. But if I now change it into these kind of, again sputum examination, but now there are these dumbbell shaped bodies. Now you know the answer is going to change too. I'm not giving you the question भी नहीं देखने का time दिया. I think even without that you can tell me this is to do with asbestos. But now I want to read further. There's a 67-year-old patient presents with chest pain and non-productive cough. Radiological investigation reveals pleural effusion. There's a large pleural mass. Sputum examination shown below, and there are cancer cells. Which of the following malignancy is associated with this? I've got an answer, mesothelioma, but I want to ask you something. You will have to tell me everything about asbestos. First I will tell FMG students, then I will tell NEET and INI-CET students. Same slide में 2 exams covered. सबसे पहले asbestos. Which industry will be mentioned over here? Either it's going to be the shipyard industry. There are two famous industries. One is going to be the shipyard industry, one is going to be the cement industry. Okay, one answer also got revealed by mistake. So one is shipyard industry, one is cement industry. Now that the answer has been revealed, if they ask you asbestos goes and attacks which part of the lungs, please note, someone working in shipyard or cement industry, when they inhale asbestos, it doesn't directly go in the lungs. It does, but it also goes to the periphery of the lungs. And what is the periphery of the lungs? Known as pleura. So can it cause a pleural tumor? Yes, it can cause a tumor in the pleura, and that is mesothelioma. And that is the most specific tumor that it causes. But the most common for every lung tumor will always be adenocarcinoma. So most common tumor caused by it is adenocarcinoma, and most specific tumor caused by it is going to be mesothelioma. So now I have a question for all of you. Tell me the entire timeline. Whenever someone starts inhaling asbestos, the first is not cancer. I mean, cancer to hoga on the last 20, 30, 40 years ke baad. The first thing that happens is just a pleural plaque. Yes, it is just going to be a pleural plaque. Gradually, that pleural plaque is now going to convert into a pleural nodule. And after that, those cancers will come up. So now imagine in the pleural plaque stage, chota sa plaque has occurred in the pleura. If the person gives a sputum examination, you will not see anything much. At the pleural nodule stage, when the nodule becomes big, now when you take the sputum examination, now you will see these dumbbell shaped bodies, which are of course called as what? As the asbestos bodies. And what have we covered this dumbbell with? If this is the asbestos fiber, we tend to cover it with iron. Guys, can I also call this the ferruginous body? Very famous question asked to you. And what is the special stain for ferru? Matlab iron, right? What is the special stain for iron, which I'm not going to write because I think we have studied this a trillion times. The color is telling me, but I will still write for my good sleep at night that I have taught you everything. That is, special stain for iron is pearls or the Prussian blue stain. That is why the photo that you see over here is blue. The shape is dumbbell shape. Very, very important. But now they ask you sequence. NEET PG student, sequence aega. First is a plaque, then is going to be a nodule, and then is going to be cancer. Which cancers? Most common, this is FMG question, most common adenocarcinoma, most specific mesothelioma. Now that I'm talking about mesothelioma, can you think of some mnemonic, PSM square, and some calcium bodies that you see in mesothelioma? Of course, who's gonna get that wrong? Samoma bodies is something we will never ever forget, ma'am. And Samoma bodies is going to be seen in mesothelioma. This every exam student knows. Now I'm telling questions only and only for INI-CET students. With regard to mesothelioma, there are 3 questions. Even NEET PG students would want to know this. Mesothelioma, there are 3 questions. And when I create that kind of a distinction, what I have noticed it, although I tell FMG students, ke chalo have a sip of water, take a 30-second break, but your human mind works in a manner that what I will tell you not to study, somehow you will end up learning that for a longer time than what you were supposed to study. That is how we work. We work in rebel mode, ma'am. If you tell us नहीं पढ़ना, ये नहीं याद रखना, वो तो हमें याद रहेगा, which is good. I mean, yaad reh jaye, because I've seen so many questions of INI-CET are coming in FMG. Coming back, what is the mutation? Yes, you are saying BAP1, but nowadays most common, see, BAP1 mutation to hai. BAP mutation is there, which is okay, but there is chromosome 9 problem. There is chromosome 9 mutation or deletion is what is very, very important. Chromosome 9 involvement and BAP mutation, INI-CET ke liye. Which virus causes mesothelioma? SV40 virus causes mesothelioma. And which is the new marker for mesothelioma that they are asking? And that is known as calretinine. These are not my new questions. These are known PYQs of INI-CET. Calretinine is the new marker of mesothelioma. That is known already. SV40 is the virus causing mesothelioma. Chromosome 9 involvement is the most common. BAP mutation is seen in mesothelioma. Very famous questions. Chalo, this is done. And I move on to the next. After INI-CET, I will come back to one FMG. I'm going in between exams. I'm shuffling between exams. I did not want to keep separate LRRs for every exam because that just somehow creates FOMO. FMG students keep wondering, हमें NEET PG वाला भी देखना है, but then someone told them कि INI-CET भी important है. So then you are juggling between three LRRs and then vice versa for every exam. Abundance is going to kill every little hope that we have of clearing this exam. We have to be very limited, very concise. Hence the single LRR, which is good enough to deal with 3 exams. Starting with this, ये तो previous year question है, ma'am. ये तो हम बिना देखे ABCD याद है अब तक हमको. So over here, as soon as in the lungs you see a patient having a coin lesion, what starts ringing in your ears is हमारे पैसे, हमारा popcorn, हमारा tissue. In case you don't know, and again talking in our own code word language, हमारा is going to be a tumor known as hamartoma. हमारे पैसे will tell us that radiologically it is going to show you coin lesion. Perfect. हमारे पैसा, who pays for the movie gets the popcorn. I mean, that's rule since college life. So हमारे पैसे, हमारा popcorn, it is going to show you popcorn calcification. Where else other than hamartoma are you going to see popcorn calcification? Breast tumor, benign breast tumor, fibroadenoma also shows you popcorn calcification. Now coming to hamara tissue, means what kind of tissue is going to proliferate? It is the native, normal, ऐसा कुछ भी word लिखा होगा. It is the normal tissue that is just going to now become a little more in number, proliferation. So over here, is it going to be, now I want to ask you a question before I start answering, because now everyone has kind of ratta lagao this question. The day examiner messes up the options, changes the statements, you are in for a toss, and I don't want that. Please note, when I'm saying native or normal tissue, which organ am I talking about? When I talk about hamartoma, the most common that I'm talking about is pulmonary, okay? And pulmonary has what all? Ma'am, it has trachea, bronchi, bronchiole, alveoli. Does it also have cartilage? Yes, trachea के आसपास cartilage होता है, we know that. When I say normal tissue is proliferating, you know what is actually proliferating? It is cartilage which is becoming more. So now if they say, is hamartoma a benign tumor? Oma matlab benign, correct hai, but is it a benign tumor of epithelial? Is it arising from columnar epithelium, ciliated epithelium? No, it is arising from cartilage. So option A is wrong. Option B says that it is disorganized normal tissue. Yeah, native tissue, normal tissue, that is the correct answer. Is it granulation tissue? Of course not. Granulation tissue तो वो wound healing में आता था, repair में था, off topic, off track. Is it ectopic tissue? No, we have always studied if हमारा tissue is hamartoma, then चोरी का tissue is corystoma. चोरी का tissue means ectopic tissue. Ectopic tissue is corystoma and हमारा tissue is hamartoma. Question done. The next topic, without which if I finish the LRR, then I am at fault. I mean, I cannot. As an educator, I cannot. Even if you know it, I still have to teach you. That is a 60-year-old man who presents with a 4-month history of increasing weight loss, wheezing and shortness of breath. Before that, sorry, example of corystoma, very sorry guys, in case you didn't know, just giving you a random example. Let's say this is the stomach, and stomach ke andar embryologically some defect had happened, and because of that little bit of pancreatic tissue is present in the stomach wall, and you'll be like, oh, this is ectopic tissue, this shouldn't have happened. This is a very rare thing to happen. Let me give you an even better example in pediatrics. Have you guys read about that rule of 2 wala ek diverticulum? I've given you every answer. You just have to tell me the name. Rule of 2 wala diverticulum कौन सा? Meckles. No, not gist. Gist is a tumor. आगे. Meckles diverticulum you've heard of? Yes, ma'am. Rule of 2. सुना है. Meckles diverticulum, can it have some extra tissue? Can it sometimes have gastric tissue? Can it sometimes have pancreatic tissue? Can it sometimes have other organs in as an ectopic occurrence in it? Someone said gastric, pancreatic. Yes, ma'am, हो सकता है. So that is ectopic tissue. That is a corystoma. Any tissue is present at a place where it is not supposed to be present is going to be a corystoma. Okay. So if, for example, if in this LRR, if let's assume a NEET UG student starts attending it, he or she would become a corystoma. Ectopic, what is not required. ठीक है, वापस आते हुए, yes, this question which I cannot miss also, this has to come in the exam. NEET PG or FMG में तो पक्का INI plus minus. I'll tell you what will come in INI. So this is going to be, someone said pearls dikha. See, that is why I got this photo. Someone said adenocarcinoma. Okay, let's just not read the history because I know you guys are not. Adeno में you see glands. See, whenever they will make glands, वो बीच में से खाली होंगे. Glands will be empty. I don't, even if you confused this to be a gland, let's assume, it's not empty. It's filled with red color material. Guys, it's a blood vessel. This is another blood vessel. Red blood vessel. Ma'am, red की जगह कहाँ red? It has become a blue blood vessel. Now you want to reconsider your answer? Yes, now you want to go into small cell cancer. And the old name, because examiners could be to, have done their MBBS 2-3 decades ago, old name of small cell carcinoma was oat cell cancer. Guys, this is not adenocarcinoma. Secondly, squamous cell, many of you said pearls. Let me show you one pearl and then maybe you will not confuse it again. You will see a pink colored pearl. Over there I'm seeing a blood vessel, and blood vessel ke aspas I'm seeing that blue blood vessel. That is totally different. That is a classical blue blood vessel which is known as Azopardi effect. And one more thing, small cell cancer is always seen in smokers. So do I have a very strong history of smoking? So much so patient ko emphysema, chronic bronchitis sab ho chuka hai. So yes, this is the classical Azopardi effect. Just in case you had thought of adeno and squamous, didn't you read this? Immunohistochemical analysis showed expression of synaptophysin. Guys, कुछ तो hint लोगे ना. Smoking is one hint for small cell. Synaptophysin is a marker for small cell. Then this blue blood vessel, Azopardi effect. So this means अगर markers में जिसने mess up करा, this is a separate question that came in the exam. What is the marker for small cell carcinoma of the lung? And that is out of these. यहाँ तो synaptophysin नहीं है. यहाँ पर what is the answer? It is chromogranin. So ma'am, let us do that effort and revise the markers. FMG students, same exam में दो questions आते हैं lung cancer पे. NEET PG INI-CET 1 question. So let let me start. I have these 4 cancers of the lung written in front of me. But if I want to act smart and I want to ask you which is the most common lung malignancy, so and what will you, and these are the 4 options, ma'am, out of these 4 options, nahi, usse bhi pehle, the most common lung malignancy is metastasis, and the radiologist will always say that whenever metastasis happens in the lungs, that is known as cannonball metastasis. That's a very famous radiological appearance that they tend to ask you. So agar metastasis nahi hai, then my answer will be out of these 4, and the most common that you have out of these is going to be adeno. Whether they say men, women, world, India, etc., etc., हर चीज का आंसर lung adenocarcinoma is most common. Which are the ones associated with smoking? S for smoking, S for squamous, S for small. So smoking में ma'am SSS. That's as easy as how you have to learn it. Now let's come to microscopy. Now please note, you told me squamous cell carcinoma shows you those pink colored things. What are those known as? Those are known as keratin pearls. Pearls wale tumor ka marker is PP wala markers. Pearls wale tumor ka marker is P40 positive and P63 positive. P40 positive and P63 positive. But the best one, best पूछा गया था. This has been asked. I mean, I don't want to repeat this again and again, but whatever I'm teaching you is either a PYQ or a potential question or important. So let's not waste time. ये आया था exam में. P40 positive is the best marker for squamous cell carcinoma. P वाले pearls, P वाले markers. Squamous is done. Let's go to adeno. I think everyone knows by now that the word adeno refers to glands. Did I tell all of you that glands will be khali khali? So please zoom in and see. You will see round glands and they will be all empty inside. That is the glands. And now for adenocarcinoma, A for adeno. So ma'am, the markers are going to be all AA and 1 wale markers. A is the first alphabet, right? So we have napsin A, we have TTF1, we have MUC1. So all 1 AA for adeno. Guys, anyone who got the previous question wrong, you had synaptophysin mentioned over here. You couldn't have marked anything else, because now I will tell you about small cell cancer. We call it chota packet bada dhamaka because the chota packet is sounding like a small one, but the list, look at the things and the markers that it's going to show you. Number 1, it shows you, look at this. This is also a blood vessel, but kahan lag raha? It's not looking like a blood vessel. It's a blue blood vessel, and blue blood vessel is referred to as what? The Azopardi effect. Now I have another question for all of you. This is for NEET PG and INI students. When we say blue blood vessel, they might ask you what is the reason for the blood vessel becoming blue. So the blue color is because of the tumor cell DNA. जो कैंसर सेल है उसका DNA has come over here and that has resulted in making it very blue. So now my question is that how do I confirm DNA? Is there a special stain for DNA? It is known as the fuel gen stain. It is the fuel gen stain. How we have learned is always DNA is the fuel to your generation, right? So for DNA, the special stain, the fuel for your generation is going to be the fuel gen stain. Dr. Shivi, I just described Azopardi effect. I hope you were with us on it. It is a blue blood vessel. Why blue? Because all the cancer cell DNA has come and gotten stuck on the blood vessel. How will you confirm DNA? By the fuel gen stain. Now let's see, that's why I said na chota packet sounding so small and naive, but look at what a major thing it has resulted in. Now let's come to the markers. The markers which everyone has to know is synaptophysin, chromogranin and NSE. ये तो सबको आना ही आना है. That is why over here option 1, if they said synaptophysin, small cell carcinoma. If they said chromogranin, small cell carcinoma. If they say NSE, small cell carcinoma. But there are total 6 markers for other exams that you have to know. Synaptophysin, chromogranin and bombesin. How do we learn it? Ma'am, in पढ़ते हैं. Synaptophysin, chromogranin, bombesin. And then we study 3 short forms, NSE, CD56 and CD57. Itna tough things also you remember. Okay, very good. So in synaptophysin, chromogranin, bombesin, 3 short form, NSE, CD56, CD57. If it was not tough, examiner then decided last year in INI-CET exam, examiner decided to ask you that okay, for small cell cancer of the lung, which is the intranuclear marker, and all of these were there in the options and students were like ke marker to pata tha, but intranuclear marker for small cell carcinoma is INSM. You don't have to know the full form, you just have to know कि अच्छा intranuclear marker कौन सा होता है is INSM. So you know, imagine when let's assume 1, 2, 3 and 4 ये options थे, ठीक है, in the exam, and they said for small cell carcinoma, oh sorry, it might not be visible. So for small cell carcinoma, if these are the 4 options given and they ask you that which is the intranuclear, anyone can get, you know, a little troubled कि मैम सारी markers थे, ये INSM क्या होता है, you don't have to know the full form. But students who had studied from me, they had to take a safe guess, and they had to take a guess because it was the INI-CET exam where you anyway are playing a little on the front foot and you're playing a little more aggressive. You want to attempt more and more of questions which you otherwise don't do in NEET PG. So then they use the kind of mnemonics we make in class, and that worked in their favor. So many students came back to me and said, मैम कुछ समझ नहीं आ रहा था, I had to take a guess. I took a guess that IN का marker IN होगा और मैंने mark कर दिया. Although the full form is not intranuclear, but it worked in their favor. So sometimes being very juvenile and being very naive in the exam also pays off. Not overthinking something, not breaking your head over something and thinking सीधा सीधा कि अच्छा let's take a safe guess. Sometimes that works in your favor. Okay, now I come back to lipidic and azopardi. Dr. Shiba is asking, firstly, we are dealing with totally different cancers. Lipidic cancer or lipidic pattern that you're seeing would be seen in a variant of adenocarcinoma, whereas azopardi effect is going to be seen in small cell carcinoma. Lipidic pattern is a condition in which on the glands, the tumor, on the alveoli, the tumor cells are sitting. So Dr. Shiva, that is known as butterfly on fence appearance. The tumor cells are sitting like a butterfly on a fence on the alveoli. That is seen in the precursor of adenocarcinoma. That is not seen in small cell carcinoma. Okay, is that okay, guys? That lipidic wala that you are saying is the adenocarcinoma in situ variant of this. It is not seen in the variant of small cell carcinoma. Why are you calling it chota packet bada dhamaka? Because what is it? This is going to be the most aggressive. This is also dhamaka, which means it is the most aggressive tumor that you have. We've not finished it because you will also revise all the paraneoplastic syndromes with me. So now I realize the longest list that we have is again for small cell lung cancer, ma'am. It is going to show you a syndrome of inappropriate radiate secretion. It will show you Cushing's disease. It will show you Lambert-Eaton syndrome also. But out of these, the most common that it will show you is going to be SIDH. But can I say the maximum paraneoplastic syndromes are going to be seen with small cell lung cancer? Chota packet bada dhamaka. For the others, there's only one name that I have to learn. How easy. For squamous cell carcinoma lung, calcium increases. So what is that? Hypercalcemia. Very good. For adenocarcinoma, we call adeno as avara because it keeps on roaming around. It's going to always roam around. What is roam around? It is going to roam around as in migratory. It causes migratory thrombophlebitis. Thrombophlebitis, again, I want to just emphasize. Itis means inflammation. I don't have to write. Thrombo means blood clot. Okay, but phlebo means what? Veins. In the veins there is inflammation. In the veins there is blood clot, and that is moving. What is this known as? Excellent. That is known as Trosius phenomena, and that means avara, roaming around. Adenocarcinoma is avara. Then everything else, dustbin category, small cell, all the other paraneoplastic syndromes in small cell. So squamous shows you calcium, adeno is avara, and everything else in small cell. Only one for large cell. Nothing, ma'am, nothing have you taught me for large cell cancer. At least teach me one thing. Large cells become large, and in men, the breast can be enlarged. And what is that known as? Gynecomastia. So large cells and large breast is going to be the only question that you might get in large cell. Otherwise, it's a very rare cancer to occur and not asked at the undergrad level. So that is done for you. Okay, some of you were asking me that, ma'am, this Trosius and migratory is not just seen in lung adenocarcinoma. It is also seen in pancreatic adenocarcinoma. I agree with you. Logic तो वही है ना. I taught you the logic some time back. Whether it is lung or it is pancreatic adenocarcinoma, they make mucin, and mucin is responsible for blood clot formation, thrombus. That is why it is going to cause thrombophlebitis, and that is why these two together, apart from causing this, was causing one heart endocarditis in the beginning that I taught you. Rheumatic heart disease था, नहीं वो तो streptococcus से था. Infective endocarditis था, नहीं वो भी infection से था. Then non-bacterial thrombotic endocarditis was also because of lung and pancreatic. Reason everywhere is the same. Wherever thrombus has to happen, lung and pancreatic adenocarcinoma come because they end up making mucin and they end up causing blood clots, thrombus. Finally done with all of this, and the lung cancers are done. No one messes up. Azopardi effect, synaptophysin, smoking ka history, pakka small cell, oat cell, most aggressive, chota packet, bada dhamaka. Moving on to the next question that we have over here. I expect this in every exam of this year because it's one of the most frequently asked PYQs and very, very important. There is a 68-year-old man with a history of smoking of 25 pack year presented with this kind of history, presented to the OPD with complaints of new onset dyspnea on exertion and abdominal pain. He had a history of prolonged neonatal jaundice. I mean, this question once came, you might have not seen it in the recent Q banks because it came a couple of years ago. And the only doubt over here was that how a 68-year-old man is able to give a history of prolonged neonatal jaundice. I mean, in our countries, people don't even give us history of last year. Look at this history, but nonetheless. On physical examination, patient had a barrel chest, diminished lung breath sounds, swollen abdomen with hepatomegaly. I can see two organs getting affected, lung as well as the liver over here. When they say barrel-shaped chest and they say hyperinflated lungs, size of the lungs is increased, hyperinflated, along with the classical history of smoking, I am definitely thinking of emphysema. Great, guys. So that is going to be emphysema. The person who's laughing the most on this is having a username, let's talk about India. Precisely what I was doing. In India, the patient does not even give you the history of what he ate last night. Forget that. He will give you one history and in front of your HOD, he will change that history. So even, minute to minute histories can vary in our country. So forget the history of neonatal jaundice that someone would tell you at the age of 68 that he had once when he was born. That's impossible. But anyway, coming to the next organ, apart from emphysema, we can also see that there is a nodular liver surface. So nodules in the liver basically means that it is going to be cirrhosis. I can see two organs affected, and with these two, if I look at, see if it would have been autoimmune hepatitis, then lung effect nahi hota, ruled out. Bronchiectasis mein lung hoga, liver nahi hoga, ruled out. Cystic fibrosis will also give me some involvement, and firstly they don't give 68-year-old patient for cystic fibrosis. They give more of a younger age group, and they tend to give you something to do with salivary glands, pancreas. All of that is not mentioned. Classical alpha-1 antitrypsin deficiency. The only hesitation I have over here is I expect a 6-8-year-old boy, not a 68-year-old man. But then when everything else was fitting, it is there. I expect not this question, but something to do with alpha-1 antitrypsin deficiency. They will ask you, what is the name? See, this is an enzyme. Now for INI-CET students, they will ask you, what is the name of the gene that makes alpha-1 antitrypsin? That is the SERPINA gene. And for every exam, they will ask you alpha-1 antitrypsin gene is present on which chromosome? It is going to be present on chromosome number 14. Very few chromosome numbers which I am telling you nahi ratna important hai. This is one of them. You have to think of chromosome number. Perfect. Chromosome number 14 over here. What is the age? As I'm telling you, it is an autosomal recessive condition. So I expect an early onset. Early onset means that a 14-month-old, 24-month-old, 18-month-old baby aisa kuch likha hoga. And what are the organs affected are in front of you? It is the lung and liver. In the liver, there is cirrhosis. Imagine a 4-year-old baby or a very young baby having cirrhosis. And the second one is going to be emphysema, as all of you can see over here. Now, one thing that I want to ask all of you, what kind of emphysema? I'm waiting for that answer. Yes. What is the kind of emphysema? Because that is something you are asked in medicine and peds both. Pan-acinar emphysema. Very good. Now, how I have learnt it is, in our country, the most common pet name that a mother gives to his or her child is going to be Lal. So the mother will say, my chota bacha Lal. That is the chota bacha history that will be given. And the mother say, my chota bacha Lal is coming to you with Lal. Lal means that is an alpha-1 antitrypsin deficiency. There is involvement of the lung and there is involvement of the liver. And then what is the special stain that you are going to put? Something to do with Lal. I mean, Lal in pathology must be pink only, ma'am. So the special stain for alpha-1 antitrypsin is going to be pass positivity. Is that okay with everyone? Yes. Moving, chota bacha Lal, suffering from Lal, stain is also going to be pass positive, which now gets me to a very important point out here, that what are all the things in pathology which are going to be pass positive? On one side, I am going to write glycogen, and on the other side, I am going to write everything else that you will tell me which is going to be pass positive. So guys, please help me. एक तो हमारे पास glycogen, this तो I told you, मतलब in biochem they say any glycogen storage disease, and you know that this is what you are going to come up with. But what if they write about, okay, let's go a little alphabetically, that will help us. A से तो मैम अभी आपने पढ़ाया alpha-1 antitrypsin. B से we can think of basement membrane, that is also going to be positive for pass. Okay, then anything else? Perfect. Whipple's disease. Achha, you guys decided to go right to the end. Perfect. Whipple's disease. We are starting with GIT only after this. Maybe you will get the question of this. What else you are forgetting? Maybe nothing with C. Go to D. Diabetes mellitus. What is the most characteristic lesion of diabetes mellitus? It is going to be the KW lesion. That is all Kimelstein-Wilson lesion. That is pass positive. What else, guys? Okay. Then one more. You are again going all the way to hemat. Ma'am, lymphoblast is also pass positive. Man liya. Perfect. You are forgetting one thing. हमारा my microbiology you have forgotten. Fungus is also pass positive. ऐसा कैसे करा? So fungus is also pass positive. So these are the main ones. Why did I make you write this? Because only pass positive glycogen वाला जो होता है, that is pass positive and diastase sensitive. That is pass positive and diastase sensitive, and everything else is going to be pass positive diastase resistant. हाँ, बीच बीच में चलो, you want to add कि मैम cryptococcus can also be, छोटा मोटा तो everything can be. I am making you learn major ones जिसके बिना तो you can't enter into the exam hall are these. Glycogen is the only one which is pass DS, and everything else is going to be pass DR. Finally done with pass. That is why I was teaching you alpha 1 antitrypsin. Moving on to a question specially for NEET and INI-CET, but I have taught you FMG students, you have also been taught. Patho mein mera distinction is very limited, very limited for every exam. KW lesion, Dr. Sanskar, if it would have been glycogen, then it would have been diastase sensitive. It is a glycosylated product, not precisely glycogen. Coming, what is BM, Dr. Prachi? Basement membrane. BM is basement membrane. Okay. Moving on, coming back, what is incorrect about fibrolamellar? ये last LRR में भी था. This question is a repeat because this topic is very important. Most of you are saying it is associated with Hep B and Hep C. I will come back to this. I am talking about fibrolamellar carcinoma. होता कहाँ पर है मैम? We are talking about liver tumors. Usually what we studied is always the simple liver tumor, that is HCC, but forget that. If I ask you which is the most common liver malignancy, your answer once again becomes metastasis. Ma'am, आज का सबसे favorite is metastasis. Cardiac का most common metastasis, lungs का most common तो cannonball metastasis, liver का most common again metastasis, and that is usually from the colorectal region. Colorectal carcinoma का metastasis to the liver are most common. चलो, metastasis is not there. Then I come to hepatocellular. I have 30 seconds for classical and 30 seconds for fibrolamellar. So please help me complete this target in 30 seconds. When I say classical HCC, you will say मैम classical का age तो आराम से 40-45 वाले age के बाद होता है. ठीक है? Number 1. Number 2, what is the gender? Okay, Dr. Ankit was there in the chat. Sorry, Ocha, now sorry sir, I missed your comment because students made me miss that. But thank you so much for joining in, sir. And sir always joins in. I think that's a very good motivation, not just for students, but for me also, because in the middle of sleeping halfway through pathology, I think it's a breath of fresh air when someone else joins in. So thank you so much, sir, for joining in. Coming back, 40 to 45-year-olds, because that's HCC, right? Gender, now that is more commonly seen with men. I mean, HCC, everyone associates, the first thing coming to our mind is either hepatitis or alcohol. And usually alcohol consumption, as it is said, is more common in men, although the line is diminishing very quickly nowadays. Anyway, is it associated with hepatitis? Yes, chronic hepatitis, that is hepatitis B and C, right? What is the tumor marker? You cannot mess up here. You mess up here, and not only would you make the examiner very upset, but me ultra upset. So what is that going to be? It is going to be alpha fetoprotein positive. We don't have time. Abhi bata do. Alpha fetoprotein is positive in 3 things, and you need to know all. First is of course yolk sac tumor. वो तो yolk sac से बनता है, तो yolk sac tumor is obvious. Second, ma'am, you are teaching me over here hepatocellular carcinoma. After this, any childhood hepatic tumor is also mentioned. That is hepatoblastoma. That will also be alpha fetoprotein positive. याद आ गया सबको? Tomorrow I will not teach you. Okay. Now coming to spread. Whenever I say carcinoma, all carcinomas go into lymphatic channels. बट हिपैटोसेल्युलर कार्सिनोमा का तो अपना पर्सनल वेन है ना, हिपैटिक वेन, पोर्टल ट्रायड एंड ऑल ऑफ दैट. तो व्हाई विल इट गो इनटू एनीथिंग एल्स? इट विल गो इनटू अपना पर्सनल वाला ब्लड सप्लाई. इट विल गो इनटू हिमैटोजीनस एंड प्रोग्नोसिस. आई बिलीव एवरीवन नोज हिपैटिक कैंसर का बुरा होता है, so that is done. But then God said everything is so bad, let me find some good in the bad, and that good in the bad is going to be, there is a variant of HCC called fibrolamellar. The age at which it occurs is very young. Have you ever heard a 19-20-year-old person having liver liver cancer. I mean, God forbid, no one should have it. But in case someone does, that is because of a deletion of chromosome 19. So it will happen at the age of 19 and it will happen due to chromosome 19 deletion. And 1919 matlab ma'am teenage ka last year, we all have gone through it, and that's a lot of tension because the good time of your life is coming to an end and now you're worried about your career, profession, job, work, money, etc. So बहुत ज़्यादा tension, nerves पे बहुत ज़्यादा tension. What is the tumor marker? Neurotensin is positive. 19 का age, 19 का chromosome, 19 tension, nerves का tension. Just a way of learning, that is neurotensin. So is it anything to do with hepatitis? No, is it not? If it's not alcohol, if it's not hepatitis, then there is no male female preponderance also. It's equal in both. How will it spread? बिल्कुल उल्टा चलेगा ma'am. This is going to be lymphatic channel, and thank God, because the patient was a younger one, God decided uska prognosis has to be good and he will survive. So now if I come back and ask you what is correct or incorrect about fibrolamellar, is it associated with chromosome 19 deletion? ये तो correct है. Neurotensin tumor marker correct है. Lymphatic route से जाएगा correct है. Is it associated with hep B and hep C? Totally wrong man है. Hep B and hep C is incorrect. It has nothing to do with it. It is chromosome 19. आखिरी दिन, you don't have so much time. Last day what do you revise? 19 19 tensin khatam. 19 19 neurotensin. Fibrolamellar cancer done. Now we are gone over here. Now we come to the next one, that is this question, which has been asked a lot in previous years. They are not sick of it. I don't know when will they get sick of it. I hope not. I hope they don't get sick of it this time also, and they give you. There is a 60-year-old person who presented with some stomach tumor and has the following features. There is a mesenchymal mass below the mucosa of the stomach with an intact mucus or a mucosa on the top. Spindle cells are seen, epithelioid cells are seen on biopsy. Now one thing, many of you read epithelioid cells and start thinking, अरे मैम ये तो epithelioid cell granuloma होगा, ऐसा कुछ होगा. So now my thing to you is that every epithelioid cell only on the basis of just saying कि ठीक है epithelioid granuloma नहीं, बाकी सब भी पढ़ना. Over here I can notice every feature over here, and a mesenchymal mass is, yes, this is a favorite gist. Last few years में gist पे हर बार नया question is coming. Whether you are FMG, NEET or INI-CET, new question is coming, which means I have to teach you start to end of gist, and that is important for every exam. You will teach me. I've got the answer. I am going to come back to this question because all of you are saying A, B, C, D correct answer hai. Matlab 1, 2, 3, 4. Okay, so if I come back and I ask you, what are the things you know? Gist is gastrointestinal stromal tumor. As soon as I say stromal, the word that comes into my mind is it is a mesenchymal tumor. It is the most common mesenchymal tumor where? Ma'am, it can occur in the gastro and it can occur in the intestine also. But सबसे common कहाँ होता है? The word that comes first is the word that is the most common. It most common occurs in the gastric region. Now coming to where does it arise from? It arises from the cells of Cajal. Guys, what is cell of Cajal? It is the pacemaker cell of your GIT. I mean NEET UG में तो वो pacemaker of heart बहुत पूछते थे, if you remember. Pacemaker of the heart is the SA node. Similarly, here they tend to ask you pacemaker of GI tract, and that is going to be the cells of Cajal. Very good. But these cells of Cajal undergo a mutation, that is CD117 or c-KIT mutation, which is the most common. And I want to ask you that whenever c-KIT or CD117 undergoes mutation, there is an increase in an enzyme. Tyrosine kinase increases, and if you know that tyrosine kinase increases, the drug of choice that you will have over here will be a tyrosine kinase inhibitor, and the name of that drug is going to be imatinib. And ma'am, imatinib pe bhi ab sare question khatam karo. Two places in path you give imatinib. One is going to be GIST and the other is that Philadelphia chromosome wala CML. After this imatinib ka story khatam. Imatinib is a tyrosine kinase inhibitor given in GIST and CML, but the reason is different. See, in both of them it is given as a tyrosine kinase inhibitor, but why did the tyrosine kinase increase in both of them is different. In GIST, why has it increased? It has increased because of CD117 c-KIT mutation. In CML, why has it increased? That is because of translocation 922, which is known as the Philadelphia chromosome. Reason alag hai, outcome same hai. Reason is different, but finally tyrosine kinase increases, so I give an inhibitor, that is going to be imatinib. Yeah, but now you get pharma questions of imatinib being resistant and all. Pharma, I'm not teaching you. Okay, like you hate it, I hate it too. Coming back, so now this is what was known to everyone. Now they've started asking you what are the other mutations that you see in GIST. The other mutations I have written, one is known as PDGFRA mutation that can be noted, and one is known as the SDH. SDH, so I'm sure all of you have studied in biochem, succinate dehydrogenase. And now what I want to tell you that if SDH mutation is there, then it is going to occur in small kids wala GIST. I mean, examiner won't write it like this, it will be written as pediatric gist. So we'll deal with it, right? So pediatric gist or small kids wala gist is because of SDH mutation. So 3 mutations, guys, because this is what was asked as new questions. Number 1, and I mean it's there in the main videos, but I take it with a pinch of salt that main videos koi zyada dikhta nahi. It is more of rapid revision nowadays, which you guys are relying on, and that is why I've added it in the recent rapid revision also, so that in case you're not seeing main videos, then you get it over there. Number 1, CKIT or CD117. Second is PDGFRA. Third is SDH. Now, I think I started a wrong topic. No, I will not teach you pharma. Then, everyone has a motivation for an exam, and I don't shy away from saying this. Like, I always tell you, which is the subject that you hate the most. That should be your motivation. I want to give this and clear this exam because I don't want to study this torture ever again. For me, that motivation was two. One was pharma and one was PSM. And then I decided that I'm never ever going to read them again, and that is the only motivation that I had. Pharma, PSM, because I've cried, literally cried with these two subjects. Micro also used to be one of them, but life had other plans nonetheless. But pharma and PSM, I have truly cried in MBBS, I've cried in prof exams, I have cried in NEET PG. So then I decided, दोबारा कभी नहीं पढ़ना. Clear this exam, pick up a branch, just get rid of them ASAP. That should be your motivation also. To each his own. सबका एक ऐसा subject होगा जो irritate करता है. That is your motivation, not to study it ever again. Coming back, where were we? Don't deviate me. Coming back to, now we come to markers. You're done with the mutations, now you come to the markers. Under markers, if they ask you which is the most sensitive marker, that is going to be, it is going to be CD117. But so simple, na? The mutation and the marker is the same. But if they ask you which is the most specific marker, that is going to be DOG1. Not many people know DOG ka full form is diagnostic of GIST. I mean, you just read it and then you laugh over it. Ki ye kya marker hai, ma'am, patho mein this is DOG. DOG is not just dog as in dog. It is diagnostic of GIST. So it is the most specific. It was made. It came into the world for the diagnosis of GIST. More specific, but for INI-CET students and NEET PG students, even CD34 is a marker. So now if I come back, CD117 or CKIT to same tha, it's the same thing. CD34 also I've added, DOG1 also I've added. So all of these are the markers that you have in case of GIST. Why did you make GIST? Because firstly it said gastro and then stromal tumor, matlab it's a mesenchymal tumor. So that is settled over here. Now someone said mine is pathology. Thanks for being so honest. But never mind, I take that also with a pinch of salt, that this is going to be the case. No one has liked pathology. That's not a subject that you've liked. But now, before we end this, adding on to your trouble, CD99. CD99 is a marker for two things which NEET PG and INI-CET students need to know. CD99 in gynae we study as that, although she's not 99 years old, हमने बना दिया 99-year-old granny, the tumor of the ovary that occurs in very, very old females. Granulosa cell tumor of the ovary, very, very good. And one tumor which occurs in children, not children but adolescents in bone, Ewing sarcoma. Yes, and Ewing sarcoma mein, when CD99 is positive, it is also known as MIC2. This is your CD99 story, and anyone who is up here, I mean, maybe for a lot of students I don't teach this in path, although I have, but for other subjects this is an integration that I'm telling you. CD99 in ovarian tumors asked, granulosa cell tumor, the tumor of the ovary that occurs in old women, in grannies, 99-year-old grannies. And CD99 when it is also called MIC2, that occurs in children or in adolescents, bone tumor, that is Ewing sarcoma, right? Okay, CKIT and KIT, no, you don't have to consider that, Dr. Pooja, it's the same. I mean, they can write. Two things you don't consider in the exam, please, now that Dr. Pooja has asked. If they write CKIT or they write KIT, they mean the same. Ignore, mark whatever is there. They write policeman, P53. Many a times policeman is written as TP53. Guys, that is also the same. Ignore, mark, P53, TP53 same. CKIT, KIT same. Okay? These are kind of variations that I've seen in the exam. Ye same hota hai. Chalo, coming back, we've done every question of GIST and you've done the treatment also, that is going to be imatinib that you studied with me. So now that you told me stomach, I've got you a collage of 3-4 photos. Bas uska photo ka mujhe fill in the blank bata do, because then you've solved 4-5 questions for me stat. Number one, if I give you a history and this is a stomach, believe it or not, it looks like a walnut, but It is a stomach. So this means the stomach has started looking like the brain. And now we will ask you that this patient has a history of edema. The patient who has history of edema is usually the one in whom protein is getting lost. I mean, protein body se ja raha hai. Protein losing, this means patient is having edema. And that disease, very good guys, is known as Menetrius disease. Ma'am, yes, Menetrius disease is more commonly seen in men. And why does this happen? Due to an increase. My options to you are TNF alpha होगा या TGF alpha होगा या TGF beta होगा. These are my three options to you. Ma'am, it is due to increase in TGF alpha. You will tell me all three after 5 minutes. Anyway, the stomach is looking like the brain. Brain matlab this is cerebriform rugae. They are giant cerebriform rugae. Acha, the rugae have become so big. They have become big and they have become useless. Useless as in they are not absorbing the protein. Sara protein ja raha hai, ma'am. All the protein is getting lost. My patient is landing up with edema. But under microscopic examination, which is the cell that you are going to see more, is going to be the foveolar cell. So there is a foveolar cell hyperplasia that we are going to notice, which is done. That makes it Menetrius disease. Before I move forward, where did you study TGF alpha? भी यहाँ पे मैम TGF को आपने ना GA मतलब gastric disease, you called it Menetrius disease. I'm writing very छोटा छोटा so that it's on the same page. When do I say TNF alpha? Read it again with me. NF alpha, no food appetite. No food appetite means that this is the marker which is responsible for a decrease in appetite. Whenever you are having fever, whenever you are saying bhook nahi lag rahi, I'm not feeling hungry, that no food appetite is because of NF alpha. And when do you say TGF beta? Is बहुत fibrosis. People who don't understand Hindi, बहुत fibrosis, you can learn it as big time fibrosis. Nowadays I've started making dual language mnemonics. So big time fibrosis, बहुत fibrosis. So basically means that this is going to be the most fibrogenic cytokine that we have. It causes maximum fibrosis, okay? So remember, no food appetite, TNF alpha, GA gastric. कौन सा gastric disease? ये Menetrius disease, most common in men, Menetrius. And बहुत fibrosis, big time fibrosis is going to be most fibrogenic. This is one disease done. Acha, stomach looking like brain, Menetrius disease. Stomach looking like a leather bottle. What do you call it? Rhinitis plastica, leather bottle. Which cancer is it? It is diffuse gastric cancer. I want to ask you, if you've gone through our internal joke, internal mnemonic, if you've gone through the glue and golu mnemonic of pathology, then you should be able to answer this. When I say rhinitis plastica is diffuse gastric cancer, you will say, ma'am, the genetics is going to be a decrease in E-cadherin. Examiner doesn't write it as E-cadherin. Examiner writes it as the gene, CDH gene. It means the same. Please, again, kuch cheeze same. C-kit and kit same. P53, TP53 same. E-cadherin, CDH same. Now, E-cadherin is normally a glue. See, you all remember that. Ma'am, E-cadherin is a glue. E-cadherin is a glue, matlab cells ke beech mein it's a fevicol. That is what we call it. It's a glue. It's a cell adhesion molecule. And if I say the glue is gone, if the glue is going to go away, patient will have GO-LU tumors. What is GO-LU tumors? Go is in front of you. Very good. Diffuse gastric cancer. I won't write it again. Diffuse gastric cancer. And LU is what? Invasive lobular carcinoma of the breast. इन्वेजिव लोब्यूलर कार्सिनोमा ब्रेस्ट, एक ब्रेस्ट का फोटो जाते जाते बताते जाओ. इन्वेजिव लोब्यूलर कार्सिनोमा ब्रेस्ट, you will study in surgery. How are the tumor cells arranged? Ma'am, they are arranged one behind the other. They are going to be arranged one behind the other. What is this known as? This is known as the signet ring appearance. Do we all agree with this? Sorry, this is the Indian file appearance. Signet ring I will show you in a while. This is known as what? This is known as the Indian file appearance. Perfect. So I will write it chota chota. I hope you can view it somewhere. Indian file appearance. You will be able to view it once the video is gone and you get a PDF. So lobular carcinoma breast is going to show you Indian file appearance. Gastric cancer shows you what? Gastric cancer, ma'am, shows us the classical signet ring cell appearance. What is signet ring cells? And this is going to be a zoom in question, but photo yahi aayega exam mein. And that is normally, ma'am, when you make a cell, you make the nucleus in the center. But here you decided that I will make a cell and I will make the nucleus on the side as if it's coming out like a ring, as if it is pushed to the periphery over here. And exactly how you are seeing these cells, all their nucleus. So now my question is, why is the nucleus at the periphery? Why is it at the periphery, guys? Because this is going to be filled with mucin. I don't think nowadays, one more thing, just a word of caution for all of you, their favorite nowadays is not asking you questions like direct batao. Their favorite nowadays is that they are going to not give you the image, they will give you the description of the question. They will say there are cells where the nucleus is pushed at the periphery and the cell is filled with mucin. Now do you know that is going to be a signet ring cell is your problem. If you have seen the photo, understood the photo, then you know it's a signet ring cell. It's, you can't mug up ki acha this is going to be signet ring bas. No, this is not how it will be given in the paper. They will say nucleus is pushed to periphery, cell is filled with mucin. You visualize acha signet ring cell, the stomach cancer that they are talking about is going to be diffuse gastric cancer. But my students are so well aware that ma'am, signet ring cells are seen in diffuse gastric cancer, signet ring cells are seen in one tumor of the ovary also, and that is known as the Krukenberg tumor of the ovary. Very, very good. Excellent. I mean, shall we stop the class? Because then you know everything, which is so, so nice, guys. So you have done all the stomach appearances, and now I'm getting you to the next question, which I think is everyone's favorite question. There is a 47-year-old male patient, got you a direct screenshot from our app to make you more familiar with the questions. Maybe you've seen them, visual memory. 49-year-old male with chronic diarrhea, unintentional weight loss, joint pain, pallor, weakness, multiple organ again. Upper GI endoscopy shows a characteristic biopsy finding suggestive of Whipple's disease. So they have asked you what? ये तो गलत कर ही नहीं सकते मैम हम. We know they are PAS positive. We don't see PAS anywhere but over here. Foamy macrophages filled with PAS positive granules. So what are we talking about? I'll show you the photo also. These are PAS positive macrophages in which layer of the intestine? Come on guys, it is in the lamina propria of the intestine, right? PAS positive macrophages in the lamina propria, that is Whipple's disease. Quickly, without asking you, which is the bacteria that causes it? It is a gram positive bacteria which is known as Tropherema whipplei. Again and again telling you, it is a gram positive bacteria. And because you said ma'am PAS positive, P for PAS, P for pink, हमें दिख रहे हैं वो pink color के macrophages. This much patho we know by now. Pink color macrophages are seen. These macrophages are where? They are in the lamina propria. How could the examiner be really sadistic and bad with you is, he will just change one word out of it. He will say PAS positive macrophages in muscularis propria. Galat. PAS positive macrophages in serosa. Galat. PAS positive lymphocytes in lamina propria. Galat. Prussian blue positive macrophages in lamina propria. Galat. How one alphabet he's changing and messing up your life. He's playing with you just like your ex. So PAS positive, macrophages in the lamina propria is what you're going to see over here. So each and every word is important over here. You cannot miss out on it. Okay, coming to the next question. Another very lengthy question, I'm sorry, but fit nahi ho raha tha. And that is 35-year-old female presents with chronic diarrhea, abdominal bloating, unintended weight loss. Usually intestine questions में सभी को bloating, weight loss और unintentional diarrhea हो रहा होता है. Now she reports discomfort after consuming gluten foods. Here I get the buzzword. You keep reading is the point. सभी को diarrhea होगा, सभी को unintentional weight loss हो रहा होगा, but then you will keep reading and you will come to a certain point, and that point is going to be gluten. Gluten means what? The bro cereals. The bro cereals I'm not writing because I think that's too juvenile a question to write for you guys. Barley, rye, oat and wheat. Barley, rye, oat and wheat. The bro cereals are gluten food. Lab test shows anti-TTG, anti-endomysial antibodies, celiac disease का diagnosis बन रहा है. They are saying that which of the following combinations of histopathological findings will you see? Okay. Yes, D. D matlab all of you are saying 1, 2, 3, 5, very tiny one. So let's understand, when I'm talking about celiac disease, what I've done over here, I've got you the normal intestine. Normal intestine has what? It has something called as these villi, and then it has something called as these round crypts. ये तो सबको पता है. But suddenly I noticed that when the patient is consuming bro, which disease are we talking about? Celiac or gluten? And did I just tell you the HLA polymorphism in this? That is going to be HLA DQ2 and DQ8 polymorphisms. Ma'am, ये तो अभी पढ़ा था. Because of this, these people, they have a genetic problem. They can't have these barley, rye, oat and wheat, and then they start forming antibodies. You have already told me antibody, anti-TTG, anti-endomysial. Which type of antibodies are they? They are IgA type of antibodies that are formed. Very important questions also. Dr. Anurag, I'll just come back to that question of yours. So IgA wala kaun sa? Anti-TTG wala antibody, anti-endomysial antibody is going to be positive. And these antibodies then say, chalo, now is time to go and damage the intestine. What will they do to the villi? Villi, ma'am, they were nice, finger long, finger-like projections. Villi gone. यहाँ पे क्या दिख रहा है? There is going to be villus atrophy, villi flat. If someone is damaging your body, someone else will fight for you. And these crypts decide, I will fight for them. So can you see these round crypts have increased in number? What do you call it? This is going to be crypt hyperplasia. Crypt hyperplasia. Next, that ma'am, obviously when they say these days, so that anti-inflammatory diet is so much in fashion, right? And they are saying that, oh, basically cut out on gluten because gluten creates a lot of inflammation, which is true in us also. But imagine the kind of inflammation this must be causing in people with celiac disease. So much of inflammation. What inflammation? There is inflammatory cell infiltrate which is going to be present in the intestinal epithelium, that is in the lamina propria, it will be there. And these inflammatory cells are usually going to be the CD8 T lymphocytes. This is something which I'm adding to your knowledge. So ultimately मुझे 1 2 3 5 ठीक लगा, and that is why you guys were right. It is 1 2 3 5 also. So now I think we are settled over here, right? Now coming back, which part of the intestine? I give you the same question, but instead of asking you this, I ask you that which part of the intestine has this biopsy been done from? Question number 1. And question number 2, ये जो आपने अभी पढ़ा, villus atrophy, crypt hyperplasia. In medicine, what is this known as this criteria? There is a criteria. Come on guys. So सबसे पहले तो medicine में celiac disease के लिए मैम, this is known as the Marsh criteria. Do we all remember this? So celiac का Marsh criteria is the same जो हमने microscopic examination में पढ़ा. Second, very good. How can we forget the DDDD? That is so good. You guys have read it. As again, my only question to you is, class में क्यों आए हो? ब्रेक लेने के लिए आए हो कि अच्छा खुद से पढ़ते पढ़ते बोर हो गए थे तो today let's study with ma'am? That is your intention because you know everything, and I'm not saying this just to like boost you up, but truly telling you this, true feedback. So now duodenum पे involvement होता है, patient को diarrhea होता है. Duodenum से तो we absorb iron, and these people will not be able to absorb iron. These people will come to you with iron deficiency anemia. They will not be able to absorb anything. Why just iron? They will not even be able to absorb fat. There will be fatty diarrhea. Fatty diarrhea is known as what? It is known as steatorrhea. Perfect. Which antibodies did I tell you formed in these patients? IgA antibodies, ma'am. Those same antibodies said diarrhea to kara diya. Now I'm bored of diarrhea. What should I do? Let me go to the skin, and now let me cause dermatitis herpetiformis, because you just had your derma LRR also few days back. So dermatitis herpetiformis may be to bullous disorder. Now which antibody comes? IgA antibody comes. And what is the drug of choice that you have for dermatitis herpetiformis? It is going to be dapsone. But what is the treatment that you have for celiac disease? Ma'am, पहले तो ये bro cereals को हटा दो body में से, tell the patient नहीं खाना, and then he will ask you that do you want me to die? खाना क्या है? What can I eat? Rice can be consumed and maize can be consumed, but usually clinically we notice only diet alone does not help, and because so many antibodies are being formed, steroids would be needed. Now all this was needed for every exam. Now my question that I have is for INI-CET students. Everything, I've just given you a quick recap of the entire topic. Celiac disease ka treatment nahi kara. You didn't give steroids, you didn't counsel the patient for bro cereals and etc. He is at a risk of what? He is at a risk of EATL. Many people believe that celiac disease ka ma'am, there's a risk of cancer, but in INI-CET it is asked, he's at a risk of which cancer? He's at a risk of EATL, that is enteropathy, because you're talking about intestine associated T-cell lymphoma. This is for INI-CET students. Enteropathy associated T-cell lymphoma. How I have learnt it is that bro cereals means everything to do with eating. So the cancer also that occurs is EATL. Okay, so bro cereals, eating, and cancer is also EATL. That is how you can learn it. Okay, coming back, ये जो criteria का question था, this was the Marsh criteria which I have asked you over here, and this question is done. I'm moving on to the next question, which I think is a pretty simple one, and I hope all of you will be able to answer it. Sorry, yeah, now it's here. There's a 4-year-old girl presents to the OPD with complaints of rectal bleeding and abdominal pain for the past 6 months. Firstly, the age is what you have to figure out. Investigations show 40 hamartomatous colon polyps. The biopsy shows cystic spaces with dilated glands filled with mucin and inflammatory debris. यहाँ आके डर लगता है मैम. because patho, right? But then when I go back to 4-year-old with rectal bleeding, ma'am, you have told us one rule, 4-year का rectal bleeding क्यों होगा? 4-year का बच्चा will not have rectal cancer, obviously. 4-year का बच्चा having piles or hemorrhoids also, usually I don't come across this, but 4-year का बच्चा having lots of polyps, and not just in the rectum but many polyps otherwise, this is very much possible. The kid is not going to have adenomas and carcinomas, very unlikely, but juvenile polyps can occur. And yes, I've got the answer. Someone's told me, ma'am, SMAD 2, SMAD 4. एक का क्यों बता रहे हो? Now that you're telling me, then you've opened a Viva question for yourself. Have I finished any session, even if it is a 30-minute session of pathology? Have you ever seen me not discuss this? So then how could you expect it this time? So now you will ask me, okay, someone asked me Dr. Campylobacter. Okay, I have a question on your username also after 3 days. From which layer biopsy is taken in celiac disease? See, it is taken from the duodenum, and because you want to see villi and crypt, the minimum you want is a mucosal and a submucosal biopsy. Utna to needed hai. If you get a proper punch biopsy, well and good, but if not, at least mucosal, submucosal, so that you can see everything that is required. कमिंग बैक, जुविनाइल तो मैम जुविनाइल था ना, छोटा छोटा बच्चा, जुविनाइल विद रेक्टल मतलब ब्लीडिंग रेक्टम, ये तो याद रहेगा. जुविनाइल जुविनाइल छोटा छोटा बच्चा, छोटा छोटा जीन्स. दे विल राइट STK 11, नहीं छोटा, लेस देन 5, एज लेस देन 5, नंबर्स ऑफ जीन्स लेस देन 5, SMAD 2 जीन म्यूटेशन, SMAD 4 जीन म्यूटेशन. दैट इज हाउ वी लर्न जुविनाइल जुविनाइल. कमिंग टू द नेक्स्ट, हम यू आर ऑन जुविनाइल मैम, हम तो 10 तक पहुंच चुके हैं. Coming to the next one is going to be, do you remember what we used to call her? We call her examiner's crush, because we have seen him not change her photo since the past 10, 12, 15 years or whatever, ever since the exam has begun in this history. That's some next level loyalty, because this is the same picture you get of a female with mucosal pigmentation, okay? And that is what they will talk about. Peutz Jeghers polyp. This is the kind of loyalty we all would want in life, that okay, this is how the loyalty should be. An examiner is very very loyal to this photo. Mucosal pigmentation, and this is the most important hamartomatous polyp, that is Peutz Jeghers polyp. It works as 11-11. When I say 11, they ask you what is the age of onset, and that is going to be, the age of onset will be more than 11 years. After 11 years it will start manifesting. Second, the gene is going to be STK 11 or LKB1 gene. So 11-11 is how you learn it. Then I've learned P for Peutz and P for pigmentation. Okay. JE for polyps are where? Most common location is going to be JE for jejunum. So when they write Peutz Jeghers syndrome, P for pigmentation and JE for jejunum, what kind of a polyp is in front of you? ये तो भूल ही नहीं सकते. Christmas tree वाला कुछ भी लिखा होगा मैम. They write Christmas tree, Xmas tree, arborizing, cauliflower, tree लिखा है तो it is this. But now tell me jaldi se, where do you see Christmas tree cataract? Where? From where am I going where? But I don't have an option. You have an exam coming up. Where do you have Christmas tree cataract is my question, and your answer is going to be perfect. Myotonic dystrophy is going to be myotonic dystrophy. Why have I written it such a weird way? Because you will now tell me everything. Abhi nahi, after 5 minutes you will tell me everything about myotonic dystrophy. But before that, very good. Christmas tree polyps are going to be seen in Peutz Jeghers syndrome. Someone said, ma'am, how do you know it's a girl? I mean, at least I think it's a girl. Okay, let's assume. But I've read the case history, that's one thing, because I've read it in the journal from which it has been taken. Secondly, I think this looks like a girl, but otherwise, good question. I'll think over it. Coming to the next one is going to be Cowden syndrome. Cowden, you guys were telling me 10-10-10, which means the gene involved is P10. It is going to be present on chromosome 10 and it is going to be Cowden. So 10-10-10. Now the story doesn't end here. Polyps to ho raha hai, but what else? In Cowden syndrome, we will also learn it with 10. Acha, someone said, is Peutz Jeghers autosomal recessive or sporadic? It has been found to be autosomal dominant also. So it is actually found to have multiple kind of inheritances, but autosomal dominant bhi hai. Coming back, it is made up of P10. Quickly tell me, what is P10? I've only told you. N for कौन सा cancer? Gynae में भी आता है, endometrial cancer. Coming to the next, T for what? T for thyroid cancer. P for what? P for ma'am polyps, because you are reading polyps. and P का B बनाया, so we make it into breast cancer also. Is that okay with everyone? Yes. So we have the polyps, the thyroid and endometrial. Now one question someone asked me later on for INI-CET कि कौन सा वाला thyroid cancer होता है? It is follicular carcinoma thyroid that can occur. That is going to be for INI. Another question for INI-CET that came is which is the skin tumor that can occur? That is going to be trichilemmoma. Tricky is basically a hair follicle. So hair follicle का tumor. These are two questions I've told for INI students. Follicular carcinoma thyroid होता है, trichilemmoma can also happen. Moving on to the next, there's another one for polyps. Benign Ruvalcaba relay syndrome. This is also because of P10 gene mutation. Polyp तो मैम इसके अंदर होगा ही होगा, but the name, I will go mad learning the name. Patient also goes similar. That is mental retardation. Coming to the last one. Did you notice juvenile में juvenile numbers, Peutz-Jeghers में 11 number, Cowden and BR में P10 gene की बात हो रही है. The only non-hereditary syndrome that you have over here is Cronkhite-Canada syndrome. Going to Canada, PR, your resident, your permanent residence, parents have not given. Basically, you will have to earn it yourself. This is non-hereditary, and if you have to earn it yourself, these means first you give Indian exams, then you give Canadian MLE, then you give whatnot. You will be above age of 50 by the time you settle over there. This is going to be above 50, and above 50, ma'am, there are some things which happen in every person, which will happen in this person also. Hair तब तक जा चुके होंगे, there will be hair loss, skin will be pigmented, nails will be broken, that is nail atrophy. उसके साथ साथ बस इसको polyp हो रहा है. All old age things basically he's having because he's anyway over 50, and along with that he's having polyps. That is Cronkhite-Canada syndrome. Canadian visa no one has given you, non-hereditary, parents have not given you. If you want to earn it, you earn it yourself, and that will make you above the age of 50. This is only way of learning it, only non-hereditary syndrome out of all of these. Now moving forward, I asked you will tell me everything about myotonic dystrophy. I wrote it this way because it shows you CTG repeats that are going to be there. Then we learn it as CTG because patient classically says that he cannot terminate grip. There is no ability to terminate grip, that is one thing. And the CT will tell you that there is going to be Christmas tree cataract that is going to be present in this patient. Very good guys, it is autosomal dominant. यहाँ तक बता दिया तो chromosome number भी बता दो, that is chromosome 19. Now that you told me everything, then might as well. Okay, नहीं वहाँ पे भी नहीं रुके मैम. He has that most amazing jawline ever, that is hatchet facies. Perfect. These are all medicine questions. So this is what they ask in patho. Myotonic dystrophy CTG repeats. Medicine mein patient cannot terminate his grip. Ophthalmic Christmas tree cataract. Coming back to patho, it is autosomal dominant with chromosome 19 involvement. And medicine mein they ask you it is going to be hatchet facies. I think we are settled for every subject over here. One quick question that we have over here is a 17-year-old girl, so above 11, comes with a diagnosis of interoception. So out of all of these, before I will let you read, out of all of these, which of them has a risk of interoception? It is examiner ka crush can have interoception. There is going to be a risk of interoception that is present in Peutz-Jeghers polyp. So more than 11-year-old with interoception, and the surgery was performed, histopathology pe wo is present, the Christmas tree arborizing, whatever. Which of the following is likely associated? 11 वाला तो मुझे लग रहा है मैम. Okay, mucocutaneous pigmentation भी लग रहा है, yes, but clubbing and retinal pigment epithelium नहीं लग रहा. So if they give you 1, 2, 2, 3, क्या लिखोगे? It is 1 and 2 options, the A and B, which are correct. Perfect. Moving on to the next question that we have over here, which is not what I will give you an answer to today. This is a homework for all INI-CET and NEET PG aspirants only for tomorrow. I will give you the answer tomorrow because this is integrated question of 2 days. Read it and just remember it. There is a 6-month infant presents with failure to thrive, chronic diarrhea and poor weight gain. I told you na, every GIT question starts with weight loss with diarrhea. Sabka favorite. Peripheral smear is given over here, some cell that you can see. Biochemical investigations reveal low level of triglycerides, cholesterol and fat soluble vitamins. With genetic mutation is most likely responsible. Ma'am, यहाँ पर I can just give you one hint that these are spiky cells. These are acanthocytes
These are spiky wala acanthocytes, and A for acanthocytes are seen in a disease called A beta lipoproteinemia. I mean, I can even tell you, and many of you have told me the correct gene mutation, but I'm not telling you because I have to teach you RBC tomorrow and these cells tomorrow. And then if I tell you today, you will read, forget, and then not come back with the answer tomorrow. You will have to come back with the genetic mutation of A beta lipoproteinemia tomorrow, and I will teach you acanthocytes again. I'm leaving it open ended. Okay. Coming on to the next question. There's a मिडिल एज्ड पेशेंट, मेल पेशेंट. सो अब दो ऑर्गन्स रह गए, एक रीनल रह गया और एक रह गया हमारा ब्रेन ट्यूमर्स. तो वी आर एट 7:20. नॉट बैड. आई थिंक बाय इफ एवरीथिंग गोज वेल 7:45 वी विल फिनिश. तो हमारा 2.5 आवर का टारगेट था. आई थिंक आई एम 15 मिनट्स लेट, बट चलेगा उतना, आई होप. आर वी ओके विद वट एवर वी हैव स्टडीड अप टिल नाउ? यस. satisfied कि ठीक चल रहा है, हो जाएगा. Confidence in case you had lost out on, I hope that is coming back to you, and if it is, then you are on the right track. Just keep up the pace and join in tomorrow also, so that in continuity आपका 5.5 hours में हो जाए. Now let's keep a target. Let's do say 20 minutes of renal, all photo fest is going to start in your life, and then we'll do 10 minutes of quick 10-15 minutes of brain tumors, and we will land up. ठीक है. लास्ट टाइम भी 15 मिनट ज़्यादा हुआ था. ओके, वेरी गुड, नाइस. तो आई थिंक दैट इज जस्ट वॉट हैपन्स एवरी टाइम. इट इज बाउंड टू हैपन. दैट हैपन्स विद यू ऑल्सो, दैट हैपन्स विद मी ऑल्सो. योर टाइम टेबल 90% 80% पूरा होता है मैम, रेस्ट बैकलॉग. सेम हैपन्स विद मी. आई थिंक कॉन्टेंट इज ऑफ 2.5 hours. It goes up till 2 hours 50 minutes or 3 hours, but that is okay. At the end of the day, as long as you have finished it, it is good enough. Okay, next, coming back. Middle-aged patient has proteinuria. You entered into the world of kidney. Based on immunofluorescence below, what is the likely diagnosis? Immunofluorescence ऐसा है कि मैम सब कुछ, everything, it's a full house party that is happening. As soon as I see full house effect, which means IgM, GA, C1, C3, kappa, lambda, light chains, everyone is there. That is classically seen in SLE. So SLE, of course, is a general path question that I will teach you tomorrow. But SLE in the kidney is a lupus nephritis. SLE kidney is lupus nephritis, which has total 6 classes. For INI-CET students, nowadays a 7th class is also being reported, but it's very rare that you will be asked. There are 6 classes that are going to be there, and they will ask you on every microscope, what are you going to see? On light microscopy, you tend to see the classical wire loop lesions. You read this word and you know you're dealing with SLE. On light microscopy, wire loop lesions are seen in which class? They are seen in class 3, 4. Total 6 classes now, so they are seen in class 3, 4 and 5, but maximum wire loop lesions are going to be seen in class 4. नेक्स्ट, फ्लोरेसेंट माइक्रोस्कोपी तो मैम आपने दिखा दिया, फुल हाउस पार्टी, एवरीवन इज गेटिंग डिपॉजिटेड. सो एफ फॉर एफ, फ्लोरेसेंट माइक्रोस्कोप शोज यू फुल हाउस इफेक्ट. इफ यू वांट टू नो द मीनिंग, GAM, C1, C3, kappa, lambda, जितना कुछ पता है, everything gets deposited in the kidney. And electron microscopy तो is looking like a forensic का photo. It is the thumbprint sign. Now if in INI-CET, imagine they don't want you to mug up and they want you to answer कि अच्छा है क्या, what is this thumbprint sign that you are seeing? I mean, even a non-medico can probably tell this is a fingerprint. But then what is it indicative of? Thumbprint sign is nothing but the same wire loop lesion if you see it under an electron microscope. So thumbprint sign is nothing but a wire loop lesion only seen on a black and white microscope. Now moving forward to a question which you cannot ignore. Any exam, if you miss this, then you are just wanting to fail in the exam. मतलब you assume that मुझे जान के fail होना है, then you are missing this. TAM horsefall protein is a major component of the following. TAM horsefall protein is a major component of renal cast, which means, ma'am, in the next 3-4 minutes you are going to tell us all the casts and crystals which are very very important. But usse pehle, can you tell me where did I teach you Kirschmann spiral? This was a part of the 3 C's that you see in asthma. In asthma you had 3 C's. एक तो वो crystal था, Charcot Leyden crystal, एक तो bodies था, Seriola bodies, and one was a spiral, that is Kirschmann spiral, totally different. Here I'm talking about a different organ that is known as the renal cast. So they mentioned TAM horsefall protein. Do you know there is something known as hyaline cast which is totally normal, which means that tomorrow if you get your urine report testing done and your report says 2 hyaline casts seen, please don't send me a screenshot saying, oh my god ma'am, my kidney is going to fail because I'm having hyaline casts in my urine. It is a very normal thing to have this cylindrical transparent kind of a cast. So the questions asked is that why is it normal? So this is going to be made up of what? It is made up of THP, that is TAM horsefall protein, and TAM horsefall protein is produced by which part of the kidney? It is made by the loop of Henle of the kidney. So now just imagine na, if a protein is made in this loop of Henle, what kind of shape can it assume? Ma'am, uske paas option is cylindrical shape. When it will come out into the urine, it will look like this cylindrical shape only. It can't become a star or a rectangle. It can become only a cylinder, and that is how it's going to come out into the urine. Now coming back, till the time this is like a cab, okay, it's like a taxi, Uber, Ola. It till the time it is coming empty is okay, but if 10-20 people are sitting on it, then that is a traffic violation. If 30-40 people are sitting inside one cab, I will be very worried. So till the time it was coming khali, I was like, okay, empty here, never mind. But now suddenly lots and lots of red blood cells are coming in it. This means the glomerulus has given up. This is a case of glomerulonephritis. That is why red blood cells are coming. What if white blood cells start sitting on it? White blood cells start sitting on it. That is a case of pyelonephritis. What is it? Glomerulonephritis means glomerulus is giving up. Pyelonephritis means tubules are having a problem. Now, what if it becomes this dirty brown? So, obviously, name is muddy brown cast, that is seen in case of acute tubular necrosis. Necrosis, what tells me kidney is dying. Acute tubular necrosis, tubules are dying. They can say, oh, mercury poisoning hua, name some chemical like carbon tetrachloride poisoning occurs. Any poisoning will kill the kidney, ma'am. But examiner का कौन सा favorite poisoning है? ATN के question में they like to give me ethylene glycol poisoning. Every examiner has favorite questions na, so their favorite poisoning is ethylene glycol poisoning, and ethylene glycol poisoning is used as an antifreeze agent. It is used as an antifreeze agent. They will say there is a sudden exposure to antifreeze agent, or there is a patient with ethylene glycol poisoning because of which he has had ATN. You will see this kind of a muddy brown cast. Final cast, it has become, it's transparent, but it's not getting something, but it's very broad, and that is the cast that you see in chronic renal failure. These are the 4 casts done. That's why I said Tam Horsfall protein is going to be seen where? It is seen in renal casts. Now we come down to cast हो गया, तो मैम crystal भी बताओ. One cast of crystal has to come unless the examiner wants to give you a very pathetic paper, then I can't help it. But then if an examiner wants to give you a balanced paper, then he would have to give you a cast in crystal. So crystal बता दो. The one with 6 sides is known as the cystine crystal. Yes, 6 for cystine is how you will learn it. The next one is going to be tyrosine. Tyrosine, ma'am, thin. The word only tells me these are going to be thin needles. That's for tyrosine. I mean, no one will ask you cystine needles are seen in homocystinuria. I mean, obviously. And tyrosine will be seen in tyrosinemia. I mean, obviously. What is the next one? This one looks like datura. It looks like apple thorn. Do you agree? This looks like apple thorn. And when I zoom into the crystal, it is looking like those spiky, like that apple thorn that I'm showing you. So this is A for apple thorn and A for ammonium biurate. That is how we learn it. Apple thorn and ammonium biurate crystals are seen. इसका बताओ, इसका नाम से नहीं पता लग रहा. This is seen because of laxative abuse. Okay, it is seen because of laxative abuse. That's the question that you are going to get in the exam. Coming to the next one. Now comes the story of the calciums. Who forgets Mona is dumb? No one is forgetting that. Mona is dumb means calcium oxalate monohydrate is going to be the dumbbell shaped. You can see that dumbbell shape over here. Whereas calcium oxalate dihydrate is going to be the envelope shaped. And now example, if I ask you, one body that I taught you today was dumbbell shaped. कौन सा बॉडी था जिसमें लंग्स में ऐसा बॉडी था डम्बल शेप्ड, ऑन टॉप ऑफ दैट आई हैड पुट आयरन? मैम, एस्बेस्टोस बॉडी वाज आल्सो डम्बल शेप्ड. नाउ यू आर सेइंग कैल्शियम ऑक्सलेट मोनोहाइड्रेट इज आल्सो डम्बल शेप्ड, बट यू आर नॉट मेकिंग अस. जैसे स्ट्रॉबेरी का टेबल बनाया, पास का टेबल बनाया, इसका टेबल क्यों नहीं बना रहे? बिकॉज डम्बल्स आर नॉट ओवर. आई विल गो टू माइक्रो, देयर विल बी अ डम्बल शेप्ड इन माइक्रो आल्सो, एंड देन आई विल make the table. Today is not the right day. Now coming to the next one. These are chips, but these chips are broken. These are broken chips. That is what is very good. That is seen in cholesterol crystal. Ma'am, we learn all the chips that we keep eating. Those chips are very rich in cholesterol. That is how I've learned it. Broken chips have cholesterol. Now the next one, uric acid, means I will get a history of gout now. That is when uric acid will be increased. Kind look at the shape. One is triangle, one is rectangle, one is some goals or something. So it has a universal shape. It can take up any shape on this planet. I don't have to learn. The last one is triple phosphate. Please learn it without a mnemonic. Baki sab is with mnemonic. So this is without a mnemonic. This is known as the coffin lid appearance. Now tell me one fancy name for the triple phosphate crystal. This is also known as the struvite crystal. And now you will tell me 2 questions from surgery. If this triple phosphate or struvite crystal decides 3 questions that I want to make a stone. Which is that stone in surgery that you get a question on? Amazing guys, staghorn calculus. ये क्यों बनता है? Which pH of urine is going to be responsible for the making of this stone in the kidney? Alkaline pH. And which is the bacteria that is going to make this? It is because of Proteus. These are 3 questions. When you have surgery LRR with sir, if you don't answer these 3 questions, I will join that session and see कि किया आंसर या नहीं किया. But anyway, if you answer it here, then it's pretty obvious you will answer it there. So triple phosphate or struvite initially are chota crystals. What shape? Coffin lid. But if they become big, they become a staghorn calculus. They will result in alkaline, or they will form in alkaline pH, and that is due to a Proteus bacteria, which I will teach you again in microbiology. Okay, now very good. So everyone has started. Ma'am, Proteus ये वही था वो जो urease positive organism था. बिल्कुल. Don't show off your knowledge. Very good. But coming back, save your knowledge for microbiology also. Coming back to the next one. Okay, coming further actually. The 10-year-old boy is brought to your clinic by his mother and complains of blood in his urine. Now, when a 10-year-old boy with blood in the urine, matlab cola color urine comes, somehow my mind automatically starts going towards PSGN, because I have already been taught that PSGN is pediatric and there is going to be cola color urine. Then I say the mother also tells you that the child suffered a throat infection. I am certain post streptococcal throat infection to hua hoga. There must have been a throat infection and then the child must have had cola color urine. Physical examination shows mild edema, hypertension, which is possible because PSGN is a kind of what? Nephritic syndrome. Don't jump to the answer. Listen to my explanation. Explanation is also important. Nephritic syndrome. Nephritic syndrome, ma'am, we have hypertension. Now, based on this, the diagnosis of PSGN is made. So, they've asked you based on what? Wasted so much of my time. I gave you full explanation. But based on what? What did you guys answer? Starry sky appearance. That is what happens in the exam. Last line padna is very important, but sometimes you will not even get the answer in the last line. It's not a 100% foolproof technique कि हो जाएगा इससे solve. So you have to read, and if you get the hint, very good. If you don't get a hint, you have to spend only 2-3 seconds. Jaldi, okay, something patho written over here, PSGN written. Let me start off. So someone said starry sky, but is starry sky seen on electron microscopy? No. Starry sky is going to be seen on, it is seen on fluorescent microscopy. So when I talk about PSGN, like you said, post streptococcal, which streptococcus? GABS, group A beta hemolytic streptococcus. Today we studied 2 very important things with streptococcus pyogenes or GABS. One was rheumatic heart disease, and now the second is post streptococcal glomerulonephritis. Yes. Okay. Now, when a person has streptococcal infection, any bacteria will activate your complement system. Common sense, whether it's streptococcus, staphylococcus, or any other bacteria of this planet, it will make your complement system work. Itna kaam kara that complement system went down. There is hypocomplementemia, complement C1, C2, C4, and all these, they get too much used. They are constantly activated, so their levels decrease. But imagine, will the bacteria stay forever in your body? No, it will stay for 4-5 weeks and it will go away. So this is a very transient event. There is transient hypocomplementemia which they are going to ask you. Now, because it is a nephritic syndrome, patient is going to come to you with cola color urine. My question was that this child had cola color urine, but before that, because streptococcus tha, to sore throat hua tha. Can you tell me what is the duration between the sore throat and the cola color urine? It is 10 to 14 days. Why? Because post streptococcal glomerulonephritis is a type 3 hypersensitivity disorder, and every type 3 hypersensitivity disorder, for its manifestation, takes 10 to 14 days. Is a question in general path. All hypersensitivity disorders take 10 to 14 days. Therefore, between sore throat and cola color urine, 2 weeks, chalo, मान लिया, 10 to 14 days, same thing. That is the time duration it is going to take. So now the mother says, after 14 days of sore throat, my child is having cola color urine. Now no one will take out the kidney of such a child, but in case you do, it shows you the flea-bitten kidney. Today I taught you flea-bitten kidney for polyarthritis nodosa. Now I'm teaching you flea-bitten kidney for PSGN. There are only 2 homeworks that I've given you. One, to put in the comments below after this session, that is we hate PSM for flea-bitten kidney kya hai. Second is A beta lipoproteinemia ka genetics. 2 homeworks for tomorrow. 2 more I will give you at the end of class. I'm not letting you go so easily. But what is flea-bitten kidney? Ma'am, it looks like a kidney which has been bitten by a flea. So no flea is coming to bite. But these dark spots that are forming are nothing but multiple hemorrhages. They are hemorrhages that have happened on the kidney. Now I look at the immunofluorescence, and this is where so many students are the most problem, they are suffering a lot. Please note, whenever you get immunofluorescence, your problem is you start focusing on what is not required. You start looking at that black wala background. Dekhna hi nahi. You just have to focus on the greens. What is the name? Immunofluorescence. What will you focus on? Fluorescence. Bas, black pe no focus. Only focus on green. Now, there are only two possibilities. Though possibilities may be confused, hona is bad. The two possibilities are either I take a green color pencil and the same green color I draw everywhere. Neither is it shining too much nor is it dark. Bilkul same color ka green. On the other hand, in this photo, I noticed that in some places the green color is trying to shine like a star. Then here it is going to shine like a star. This is shine like a star. This is shine like a star. So when it is trying to shine, it is those stars, and the rest of it which is not shining is the sky. This is known as starry sky appearance. Someone said electron microscope. No, it is, you are right, but it is seen on immunofluorescence. Because I will ask you, what is seen on electron microscope? They are subepithelial humps. That's a very famous question. There are these four buzzwords for PSGN. Number one is cola color urine, second is flea bitten kidney, third one is starry sky appearance, and fourth one is subepithelial humps that you're going to see. Now my question to you is, if starry sky appearance is seen in PSGN, the linear immunofluorescence is seen in which disease? It is seen in GPS, matlab good pasture syndrome. Good pasture syndrome is which RPGN? Good pasture syndrome is going to be RPGN type 1. These are the only two that you have to know. One is linear kiss mein, good pasture syndrome. One is starry sky appearance, kiss mein, that is going to be PSGN. Now PSGN was P for, ma'am, you told us pediatric with cola color urine. On the other hand, if there is an adult with cola color urine, you will think of IgA nephropathy, and IgA nephropathy is Burgers. I hope you did not get confused with that dusra wala Burgers. The dusra wala Burgers had a U in it. The U, remember the BD smoker, the U wala Burger was the V wala Burger. U, V, but the Burgers without the U is the kidney problem. IgA nephropathy, what is getting deposited? IgA1 is getting deposited, to be very precise. And now I want you to notice something. If I say that there is a sore throat followed by cola color urine in 10 to 14 days, what did you think of? Bachcha tha ma'am, 10 to 14 days mein hua PSGN. But now the same thing, if I would have written in 3 to 4 days, now your answer would have become Burgers. Now your answer would have become Burgers. The only difference is PSGN would occur in a child and Burgers will occur in an adult patient. I'll repeat once again. First you look out in the question, child hai ya adult. Pediatric hai to PSG and adult hai to IgA wala Burgers. Then you look at the duration between sore throat and cola color urine. If it has taken proper 2 weeks like a hypersensitivity reaction, it is PSGN. If it has happened in 2, 3, 4 days, jaldi, then it is a case of Burgers. Over here, I think everyone understood the starry sky appearance, which was clear cut. I want to ask you the next question, which is again, I've got you something from the Q bank. There's a 6-year-old boy presents with sudden generalized edema and frothy urine. See, whenever they write frothy anything, this is a concept for you guys. If they write frothy stool, they are trying to tell you that something is coming out in the stool. Maybe it's a steatoria, maybe it's a fat. When they say frothy urine, then something is coming out in the urine. Maybe protein is coming out, maybe protein and fat both are coming out. So that would be a case of what? That would remind me of nephrotic syndrome, that something is coming out into the urine, right? That is what makes it frothy. Plus, the urine analysis reveals proteinuria as expected. That is why it was frothy without hematuria. See, blood is not coming out. What have they ruled out? They have ruled out nephritic. Blood comes out in nephritic, right? So they have ruled out. Renal biopsy shows effacement of food processes. As soon as they write it, it is minimal change disease. Now they have asked you what is true regarding this condition. As I realized, most of you answered C, which is a good response to corticosteroid, which is correct. If I read other options, I will see lipid deposition within the glomerular capillaries. This is partly correct and partly wrong, because if all of you made it what? You made it minimal change disease. The reason for calling it minimal is because the light microscopy is otherwise normal. If you ask me, light microscopy of kidney means what? Light microscopy of glomerulus, ma'am, that is normal. So then why did you call it minimal change disease? You should have called it no change disease. Koi change nahi hai. Minimal change to hai, and that change is lipoid nephrosis. Lipoid means lipid, but do you know where the lipid is? In the tubule, proximal convoluted tubule. So does it show you the lipid? Yes, but does it show you in the glomerular capillaries, within the glomerular capillaries of the tubular cells? No, it shows you only in the PCT, not in the capillary. So this is ruled out. Does it show you immunofluorescence of IgG and C3? No, because minimal change disease ka agla naam is nil deposit disease. It is not going to show me any deposit on immunofluorescence. This is also settled. See, names are said for a reason. Hardly chota chota change dekha, lipid in the PCD, nil deposit disease, there is no immunofluorescence. So light microscopy cannot diagnose, immunofluorescence cannot diagnose. The only thing that can diagnose, what is the gold standard, guys? It is going to be electron microscopy. These are the only two pictures. The first electron microscopy is normal. What are these processes known as? These are known as the foot processes, and I'm telling you this is the normal kidney. Now I'm saying in the second photo there is a flattening or the effacement of the foot processes, and that is what is seen. Now because the feet are flattened, the feet or the visceral epithelium is flattened, the patient cannot absorb the protein well. There is selective proteinuria. Now when I say proteinuria, you will say, ma'am, wo to tha hi. Frothy urine, protein was going out into the urine, protein in urine. But selective proteinuria means it is selectively which protein going out into the urine? It is going to be albumin going out into the urine, or albuminuria, and that is always going to come across with a very good response to steroids. Thus it is very important, if I give a report of proteinuria versus only albuminuria, the surgeon or the clinician knows what to give. Finally, non-selective to galat ho gaya na, because I'm saying it is selective proteinuria. This is done. But now I want to ask you a question. Is effacement of foot processes specific to minimal change disease? Because हमने तो ऐसा ही पढ़ा, ma'am, that if I see the effacement of this, I'm telling for INI-CET students, if you see effacement of foot processes, of course 99% you are thinking of minimal change disease, but can it also be seen in FSGS? And the answer is yes. But the difference is, see, both of them are nephrotic syndrome, but minimal change disease is minimal sa bachcha. This is something which you see in child. It is the most common nephrotic syndrome in child, whereas FSGS is the most common nephrotic syndrome that you see in adults. So for INI-CET students, knowing effacement of foot processes, minimal change disease is good, but can also be seen in FSGS. Now first I will teach you, or I will ask you, although obvious ho gaya ki question is going to be on FSGS, but we will still study. You will tell me the buzzword over here. Ulta batao. Why have I marked it as FSGS in this question? What is that buzzword? A 33-year-old male patient comes with nephrotic range proteinuria. Adult है, nephrotic है, FSGS ही सोचना है. और कुछ radiologically confirmed reflux nephropathy, renal biopsy and immunofluorescence reports stand pending. कुछ नहीं पता अभी. Which of the following is the most likely working diagnosis? Working diagnosis means without a report you make a tentative diagnosis. So ma'am, reflux के basis पर it has to be FSGS, because FSGS works on these HRs 3, 2, 1. These are the 6 clinical histories that you can get. Number 1, patient will either be HIV positive, or will be hypertensive, or will have some kind of heroin drug abuse. HIV, HTN, or heroin drug abuse. Ours are going to be reflux, like in this question, reflux nephropathy was confirmed radiologically, or there is some renal tissue loss, kidney donate ho gaya, kidney accident mein chala gaya, or some cancer happened, the kidney part had to be removed. So because of some kind of renal tissue loss. And last, S is going to be sickle cell anemia. Guys, this time I really expect a question on sickle cell anemia in every format, because tomorrow I'm going to tell you one of the biggest updates that have happened in sickle cell anemia. That update happened so recently, even after me recording the main videos. I am still again editing them and getting that updated, because it happened very, very recently. So sickle cell anemia, tomorrow we will talk about it. But for the time being, in the kidney causes what? It is going to cause FSGS. HRs, if you get these histories, it is FSGS. But guys, hang on, is there any classification for FSGS? Colombian classification I have not written. Please help me fill in the blanks. FSGS is of 5 types. They give you questions of 3 types. हमें 3 types जानने हैं. One is FSGS not otherwise specified, which is the most common. You guys know that update. Very good. Beta 7 वाला बिल्कुल वही, but कल वो पढ़ना है जब हम मैथ पढ़ेंगे. Second is going to be FSGS of the glomerular tip type. Is going to be glomerular tip type. And third is going to be FSGS of the collapsing type. Now obviously the word collapsing tells me glomerulus collapsed, kidney gone. This is going to have the worst prognosis for the patient. versus the glomerular tip type is very, very good because tip, little teeny tiny little glomerulus involved, so it is very, very good for the patient, and collapsing type is very bad. So where do you think HIV falls? Is HIV the most common disease? Of course not. Is HIV a good disease? Certainly not. Is HIV a very bad disease? Definitely yes. So HIV would be associated with the collapsing type, and they don't write it as HIV, they write it as HIVAN. Don't feel koi new disease diya which you don't know. HIVAN is nothing but HIV associated nephropathy. I mean, it's the common sense thing written in the form of a sentence, and they're trying to act smart out of it. Sentence ko they made a short form. HIV associated nephropathy. It's an HIV disease, of course, very, very bad. Now coming to the next question. There is a 45-year-old female patient with rheumatoid arthritis and is being treated with penicillamine. So there's a history of a drug. After a routine checkup, the patient is found to have proteinuria. They've not mentioned massive or mild, but let's assume it is nephrotic, because if they mention proteinuria, it must be significant, I'm assuming. Microscopy is shown below, which, it again, always this happens in every session. It gets copy pasted to the other thing. So I'll just show you quickly. Just have a look at it once. Just have a look at this because it couldn't fit in that slide. It's come up here. Scan through it, go through it. Same photo you've seen in every grand test. Now we'll come back. Now tell me that which of the following is likely associated with their condition, and how did you photo देखे बिना भी हो रहा है answer, which is so good because मैम photo तो वैसे भी हमें ज़्यादा help करने नहीं वाला था. As per you, photo was going to help, but ma'am, we are smarter. हम बिना photo के भी diagnosis बनाते हैं. All of you have decided that after drugs, the nephrotic syndrome that tends to occur is membranous glomerulonephropathy. And membranous glomerulonephropathy most commonly occurs due to antibodies against PLA2 receptors, that is phospholipase A2 receptors. But I have also taught you, and you are right, I am showing you the spike and dome pattern. So there's something going to be spike and dome, spike and dome, spike and dome. But I want to ask you that what exactly is it? So when you're talking about membranous glomerulonephropathy, कोई तो reason होगा. Like you said, there are antibodies against what? Antibodies against PLA2 receptors, phospholipase A2 receptors. So some antigen antibody thing has happened. Or there is some drug, like in this patient there was penicillamine. Now that drug, please note the names. You will study this day after tomorrow, I think in the medicine LRR also. NSAIDs हो सकता है, gold हो सकता है, penicillamine हो सकता है. इनका favorite 3 drugs that they like to give you for MGN. Then it could be certain infections. What all infections? That is going to be hepatitis B, hepatitis C, then syphilis and schistosoma. I have already shortlisted the infection. I tell this in every session. That problem is that when I give you a list of 10 things, you would say that ma'am, I will learn 5. And then that is a filtering out, which every student does. I have also done during my time, but now please note, I have done the filtering for you. This was anyway a list of 10 things. I have given you 4. Don't mess up on this. Don't make it 4 का 2 याद करा, 4 का 4 याद करना है, ठीक है. Moving on to the next, it can also happen with cancers. They might write lung cancer, colon cancer, skin cancer like melanoma, any cancer would do. Drugs, infections, cancers, antibodies, they make antibodies. And do you know where those antigen antibody complexes deposit? That's the dome. The dome that is formed over here is the antigen antibody complex. Then who's making the spike? The spike is going to be made by the basement membrane. See, if something is coming and sitting in your body, you are not going to keep quiet and tolerate all the trauma and the torture. You will fight back. So when antigen antibody was coming, then at that time there is going to be a sudden spike up and basement membrane spikes up. That is spike and dome pattern. And now I want to come back and show you that they have only one picture of spike and dome pattern. So get familiar with it and learn it well. These are all the capillaries. These are all the basement membranes. If you look carefully, the basement membrane is showing these spikes. You can see that spiky thing going up. That is the spike happening over here. Get used to seeing this photo multiple times because the same photo shall come in your exam. This is the spike and dome pattern, and very good. Many of you have asked me that what deposits happen over here. It is going to be the subepithelial deposits that are going to take place. These are the subepithelial deposits that are going to take place. Now this was spike and dome pattern seen in MGN, but there's something else written, Dr. Sangeeta, which I'm coming to, is tram track appearance, because the next disease that you have is going to be MPGN. MPGN is of 2 types, that is MPGN 1 and 2. Ma'am, क्या history आता है? How do we differentiate? See, MPGN type 1 can also be associated with hepatitis B and C, and I think Dr. Sangeeta, this is what you were asking me. Yes, it can be associated, but which is more common, which is less common? I don't want to go into that debate right now.
क्योंकि हेपेटाइटिस बी एंड सी का तो ना दैट कॉमन लेस कॉमन वाला विच इज मोर विद ट्रांसफ्यूजन, मोर विद कैंसर्स, मोर विद क्रॉनिसिटी, मोर विद MGN, more with MPGN. Can we leave that for microbiology? Because I don't want to give you half list right now, half list that time. Can I give you the list all in one place when we do hepatitis in detail and when we come to microbiology? But for the time being, Hep B and Hep C can cause MGN also. Hep B and Hep C can cause MPGN type 1 also. And MPGN type 1 shows you the tram track appearance. What is tram track? Like today in radiology, you studied it in bronchiectasis. Over here, you are going to study that the capillaries are going to show you these two lines. The capillaries are going to show you these two lines, and these two lines are what? This is actually what I see over here. The basement membrane is showing me this kind of splitting. Tram track appearance is noted. Again, the same photo that I'm going to get. And where do you see MP? When do I mark MPGN type 2? Ma'am, MPGN type 2 will always show you a blood test positive known as C3-NEF. C3-NEF stands for C3 nephritic factor, and they will say that the blood investigations have shown a C3 nephritic factor positivity. Now, only for INI-CET students, you have to know that MPGN type 2 is also known as dense deposit disease. You see a very dense basement membrane, and hence it is also known as dense deposit disease. Maybe for NEET PG students, but this is not important for FMG students at all. But NEET and INI should know MPGN type 2 is also known as DDD, dense deposit. What is looking dense? They don't usually give you a photo, but it's the basement membrane which is going to look very, very dense over here. Is that okay with everyone? Can we go on to the next question? I've not given you options because बहुत कुछ with options हो गया. Let's see if you can answer this without options. And let's see if we are somewhere on track. Dr. SK, yeah, that's black looking in color, so that is a silver stain. The one that is for spike and dome that you are asking me, that is going to be the silver stain. Okay, here we have a 25-year-old female, no option. Edema, hypertension, significant proteinuria and hematuria. Kidney biopsy reveals mesangial and endocapillary hypercellularity with mesangial and subendothelial electron dense deposits. Tram track appearance on silver stains and granular staining. What is your diagnosis over here? Ma'am, everything was very confusing and hence I gave you this question. It was hypercellular also, subendothelial also, but as soon as they said tram track appearance, the clarity about MPGN type 1 came to me, and that's how important it is. I know that I'm teaching you this right at the end, whereas I should have taught you right in the beginning, and I'm severely over time, and I'm very sorry because abhi tak CNS भी नहीं शुरू हुआ. But are you guys willing to study for 15 more minutes and wrap it up? Because why leave it for tomorrow? I want to finish off today's target today and then go on tomorrow. ठीक है, तो can we do that? Just 15 more minutes, and I'm sorry for taking up so much of your time, but it's the only reason this LRR lengthier than previous one because I've added more questions. More questions, matlab the timing had to go up, but nonetheless, see what I'm trying to draw over here is that whenever you are in confusion ke kahan subepithelial, kahan subendothelial, I'll give you a very simple trick. This is what? This is going to be podocyte, theek hai? This is going to be podocyte, and podocyte is also referred to what? The visceral. This is where I'll take 2 minutes extra because this is very important. This is the visceral epithelium of the Bowman's capsule. Below this, what we have is going to be the basement membrane. This I'll draw over here. And below this, we have the capillary endothelium. So that I have drawn in case of red color because that's the capillary cells. Now, when I say that the deposit is subepithelial, means the deposit is over here. Subepithelial deposit is going to be over here, that is below the podocyte. So tell me guys, which all diseases show you subepithelial deposits? Which all diseases show you subepithelial deposit? Ma'am, subepithelial is like touching feet. Podocyte is what? Podocyte is feet. So touching the feet. Who touches feet? Very small kids. It's our culture. Small kids. PSGN wala kids. They touch the feet to take blessings of older people, elderly people, which is the nephrotic in elderly, MGN. So the chota sa bacha, young kid touching the feet of an older person, MGN is how I've learnt it. PSGN is most common nephritic in children, MGN is most common nephrotic in old people. So for one in young, one in old, I talk about touching feet. Now everything else falls into place. That okay, if they'd ask me that below the, over here ma'am, below the
endothelium, if the deposits are happening, then everything else can definitely go over here. For example, MPG and type 1, if it is asked, then that will automatically go in subendothelial. Over here, I could see maximally subendothelial word being mentioned along with tram track appearance, and that is why I'm saying subendothelial. These are the three main diseases in which they ask you where is subepithelial and subendothelial, and I hope you will not mess up on this. For INI-CET students, apart from this, they will ask you that जो Berger's disease होता है, which is also known as the IgA nephropathy, where is the IgA getting deposited in the kidney? It is getting deposited in the mesangium. This is the extra question that can come across to you as an INI-CET or a NEET PG student. This is what I had to tell you. So anyone who had a doubt up till now, subendothelium plus tram track going in favor of MPG and type 1. Coming to the last set of 3-4 questions. Quick answers. Last 10 minutes, you guys are the most active. Can I increase my speed to 2x, which is your usual way of listening to me, right? Where does FSGS deposit? FSGS does not have a particular deposit to know. That's why I told you it can show you effacement of food processes. That is more important to know that the deposit. Okay. Ubiquitin deposition kahan dikhta hai? Ubiquitin deposition is going to be seen in Huntington's disease. So ma'am, actually we always study for Huntington because hunting in a cage. Can you fill in the blanks? That's the way we learn it. Huntington disease will be hunting. Cage will tell me that this has CAG repeats. They are present in which part of the genome? They are present in the exon of the genome, and along with that a cage will always have a char divari. It will have 4 walls. So which chromosome is this going to get affected in? It is chromosome 4. But hota kya hai? What is Huntington's disease? In this disease, basically there is an increase in 2 proteins. One is Huntington. No one will ask you such a stupid question. The other protein that increases is going to be ubiquitin, and that is exactly what has been asked over here. This is the same question from rapid revision, hence that black screen screenshot that you've got over here. Now the ubiquitin is going forward, and ubiquitin is getting deposited in which nucleus? That is the next question of Huntington disease, in the caudate nucleus. And when it gets deposited, what is the clinical feature? It is going to be chorea, jerky movements, purposeless jerky movements. Very, very good, guys. I got every answer in order of how it has been taught in rapid revision and main videos. You guys have not only just learnt it, you have learnt it in the same order. कि अच्छा जिसके बाद next question ये होगा, then ma'am will ask this, then she'll ask this. It's the same question that you have learned. Perfect, perfectly put up. So this is easy. Let's move on to the next question. A known case of neurodegenerative disease, which is the most common cause of dementia in humans, I think I've anyway got the answer as Alzheimer's. Pata hi hai. Showed the following finding, that is on HNE. Which of the following best describes the composition of what we have? So I can see something like a flame cell over here. It's looking like a cell on fire, and flame cell in Alzheimer's is known as neurofibrillary tangles. Everyone marked it as tau protein. See, Alzheimer's also shows you A beta amyloid, but they asked you the composition of the flame cell. So when I talk about Alzheimer's versus, because you know I have so many things, if I ask you the first two options, A beta and tau protein are in Alzheimer's, alpha synuclein is in which disease? Alpha synuclein is in Parkinson's, and ubiquitin right now I studied in Huntington. So why don't I study all of them together? Huntington disease to pad liya. Now I'm left with Alzheimer's and Parkinson's. First tell me their genetics, then I'll tell you the pathology. Let's do a deal. You tell me genetics, I tell you pathology. Genetics, Alzheimer's disease ke 4 genes. INI-CET students, be ready for a question this time. This is going to be APP gene on chromosome 21, means amyloid precursor protein. That is why it is A beta amyloid deposition that occurs in Alzheimer's disease. Number 1. Number 2 is going to be PS1 and PS2 gene. PS stands for presenilin. It will remind you of presenile, old age wala, to haan, Alzheimer's disease. And it is also associated with ApoE4. Yes, ApoE4 is going to have early onset, and it is also going to be resulting in a more severe disease. So please note, APP gene matlab amyloid precursor protein, tabhi amyloid deposition happens. PS1, PS2 and ApoE4. This is the genetics for Alzheimer's. What is the genetics for Parkinson's? Because if you know the body and the composition is the same as the gene mutation also. The gene mutation and the composition of body in Parkinson's is the same, and that is going to be alpha-synuclein. Now coming back, when I'm talking about Alzheimer's, I'm not writing it as dementia, you know it. Iske andar what you get to see are going to be the flame cells, and right now you guys were telling me flame cells are also known as neurofibrillary tangles, and neurofibrillary tangles are made up of what? Tau protein. Now one question for every student: Alzheimer's occurs at 70 years and above, the age of Tau G in your family. So Tau G wala disease is going to show you tau protein. That is one thing. Now coming to the next, Alzheimer's also shows you Hirano body. So Tauji is usually the eldest person in the family, and you will see the eldest ones in the family always tries to act as a hero. कि मुझे सब आता है, I know, I will take all decisions, and hero will always be famous for his acting. So Hirano bodies are what? They are made up of actin, and this is how Hirano body looks like. Please now not to get confused. If this is a photo, even as a pathologist I'm saying it, ये photo है, and I say this is the sputum sample of an asthma patient, what is this crystal going to look like? The sputum sample of an asthma patient, I would have called this Charcot Leyden crystal, even I would have called it. But if I say this is a brain biopsy from a patient of dementia, then I would want to call it, it is going to be the Hirano bodies. What is it made up of? It is made up of actin, not made up of actin. So this is Alzheimer, flame cell made up of tau protein, Hirano body made up of actin. Coming to Parkinson, Parkinson is what? A decrease in which neurons? No one wants to write it because it's pata hai, dopaminergic neurons. If the dopaminergic neurons and dopa levels are going to be decreased, automatically melanin nahi banega. If melanin is not formed, the substantia nigra is going to be very, very pale. So there is a pale substance. See over here you can see the brown color normal substantia nigra. Over here you can see a pale substantia nigra which is going to be seen in Parkinson's disease. Ma'am, we already know this. Now we come back to the bodies, Lewy bodies. The genetics, alpha-synuclein. What is Lewy body made up of? Alpha-synuclein. So coming back, alpha-synuclein would have been the question of Parkinson disease. Ubiquitin and Huntington, that is for Huntington disease. Tau protein over here because this is the flame cell or the neurofibrillary tangle. And if amyloid would have been asked, it is the A beta amyloid. Now moving on to the next question that we have over here, one that is obviously going to come in some exam or the other of this year, pakka. MRI done, because not just gut feeling, it comes every time. MRI in a 28-year-old male suffering from NF2 showed an ice cream cone appearance. NF2 का दूसरा नाम is what? It is neurofibromatosis 2. It is bilateral acoustic schwannoma. Bilateral both sides. Schwannoma is a nerve tumor. Acoustic means cranial nerve 8. It is showing ice cream cone appearance. Okay, ringing sensation because acoustic progress to balance problem, hearing loss, microscopic finding has to be antennae A and B cells. Yes, and that is everything about the schwannoma that you are trying to study. So when I talk about schwannoma, like you all called it bilateral acoustic schwannoma, the word acoustic will tell you that it will involve the cranial nerve 8, and that is famous to show the very, very important, and this is probably the only photo that they have much in the exam, that is known as an ice cream cone appearance. Now when I look at this, it is known as NF2. 2 times 2 means that is going to be chromosome 22. A question sun lo, that if they say that there is bilateral cranial nerve 8 involvement, which is the chromosome responsible for this, that's an indirect way of asking the same thing. Bilateral cranial nerve involvement, 8 number involvement, matlab it is chromosome 22, that is NF2. Now when I look at it under the microscope, I am going to see antennae A and B areas. Antennae A, याद है, a lot of cells means hypercellular. Antennae B means blank, it is not going to have any cells. A for a lot of cells, B for blank. So this is antennae A, hypercellular, B for blank, it is not going to have any cells. Which bodies does it have? It shows the Verrucke bodies. What is Verrucke bodies? All of you were saying palisading. Palisading matlab nuclei are parallel. Can we all see blue color nuclei back to back? Can we all see blue color nuclei back to back? Yes. So this is all blue color nuclei that are going to be back to each other. So where is the cytoplasm? All the cytoplasm is going to come in between. Dr. Arvind, I'll come back to the MGN question if you have any doubt, okay, just as I finish this topic. Okay, so now what do we have? So ma'am, I can see nuclei and nuclei going back to each other, and then we have the cytoplasm in between, and if that is in between, this means it is a Verrucke body. Everyone's got it. Let me ask you an indirect question. Verrucke body has so many cells. Is it from antennae A or is it from antennae B? Which part will it be seen? Verrucke bodies are going to be seen in antennae A area. You just did a dermatology LRR. Can you tell me palisading of nuclei is seen in which skin tumor? तीन ही तो ऑप्शंस है, स्क्वामस सेल कार्सिनोमा, बेसल सेल एंड मैलिग्नेंट मेलानोमा. Palisading of nuclei and skin cancer is BCC, basal cell carcinoma. Very good. Moving on to the next question. Some of you had asked me, answer to यहाँ पे मिल गया. When you say NF2, which are the brain tumors that can occur in NF2? All of them, because many of you were writing miss me, miss me. So now note, it is going to be multiple schwannomas. I mean, वो तो नाम ही था ना, multiple schwannoma तो has to occur. Apart from that, there are two more brain tumors. One of them is going to be meningioma and the other one is going to be ependymoma. These are the three things: schwannoma, meningioma, ependymoma, which all come under NF2. Repeating once again, chromosome number 22. Moving on to the next question, which I expect again one or the other brain tumor will come. There's a 12-year-old boy brought to the clinic by his parents with a complaint of headache, especially when he wakes up. So first, whenever in brain tumor, segregate. Is it a childhood brain tumor or an adult brain tumor? Difficulty seeing the board in class, episode of unconsciousness. Image has been shown which shows you these pink color fibers. Now pink color hair, like I think of pylo means hair. This is a pilocytic astrocytoma, which anyway they have said most common benign primary brain tumor in children has to be pilocytic astrocytoma. So whenever they are talking about childhood tumors, please note, if they mention the 3 C's, 3 C's means that if it is a child and there is a cystic lesion that is going to be present in the cerebellum, child with cystic lesion in the cerebellum, it is obviously going to be a pilocytic astrocytoma, 3 C's. And pylo word matlab, ma'am, you are going to see something hair-like. And hair-like arrangement matlab rosenthal fibers, these pink fibers. The only thing that you will tell me is going to be the mutation, and the mutation is going to be the BRAF का कुछ भी लिखाओ. If they write BRAF Kia fusion, that is also acceptable. And if they write the BRAF V600E mutation, that is also going to be acceptable. As long as the word BRAF is written, I think that is going to go well with pilocytic astrocytoma. But this was what? Grade tumor. This is grade 1 tumor and I am very happy about it. Bacha will be surviving well. Prognosis is good. They change it and they say now the bacha is having a grade 4 tumor. Grade 4 blastoma. Blastoma, I've always taught you, is a bomb blast in the brain. Imagine the same bacha in the cerebellum now has a very bad tumor, and that is medulloblastoma. So medulloblastoma is famous for showing which rosettes? How can I end the session without rosettes? So the rosettes that are going to be the Homer right pseudo rosette, which is making me come to a point. Where do you see rosettes? This is for you guys. Rosettes means what? That the tumor cells are going to be round like a rose. So these are going to be the tumor cells. And now I want you to tell me that if there is pink material present in the center, that makes it a pseudo rosette. And if it is a clear center, then that is going to make it a true rosette. How did we study it? Pseudo, fake people have hidden intentions. True people are clear-hearted, right? So what will you find the most in your preparation? Pseudo people, they will have hidden intentions. They will tell you something else, galat answers, galat number of revisions, 10 revisions they've done, like that. Bad intentions they have. But very rarely will you find a clear-hearted person. And that is the person you have to keep for a lifetime as a friend. So coming back, flexna intestina true rosette is only and only going to be seen in retinoblastoma. But Homer right pseudo rosette is going to be seen in, remember we used to study in our videos, men are, and then I've left it to you, whatever life has taught you, men are right or men are fake, whatever you believe in life. So what is men are? Number one, the tumor that we are dealing with over here, that is medulloblastoma. Another blastoma, that is neuroblastoma. Even retinoblastoma can show it, which means retinoblastoma can show both, but more commonly retinoblastoma shows you the true rosette. The only non-blastoma tumor over here is going to be the bone tumor, that is Ewing sarcoma. Okay, now no debate over here guys, वो बाद में decide कर लेना. Men are pseudo, men are right. जब तक exam है, you decide. Okay, now coming back, when I was talking about medulloblastoma, it is Homer right pseudo rosette. So now see for yourself, if you see round cells with pink material in the center, round cells with pink material, that means pseudo, hidden intention, pseudo rosette. Versus if you see round cells and empty center, round cells and empty center, that means it is a true rosette, clear-hearted person. Okay with everyone? Can I move on to the next question, which is, I mean, without it again I cannot finish the session. 55-year-old man presents with seizures and muscle weakness, but no neurological other signs are there. Only seizures and muscle weakness. CT scan shows a mass that is there, and a craniotomy was performed. Histological shows you that classical serpentine. Okay, many of you have marked A. A matlab, are you marking co-deletion 1p19q? But co-deletion 1p19q is seen in oligodendroglioma. Guys, this is serpentine necrosis, which makes it glioblastoma, and glioblastoma, most commonly, very good, shows you the IDH wild type of mutation. So let me now focus on this once again. These are the three last tumors that I have to teach you for the day, and I think we'll take 3 minutes to finish it. Number one, you're saying glioblastoma. I've always taught you the word blastoma comes and you're like bomb blast in the brain, very bad. Medulloblastoma, grade 4. Glioblastoma, grade 4, very bad. And glioblastoma, I told you, is like wildlife. Wildlife मतलब animals की बात करो. If you are asked which IDH problem is there, you will say IDH not of mutant type, IDH of wild type is most common. How does it look under radiology and gross? Ma'am, it looks like a butterfly because it's on the left and right both. How does it look under the microscope? I can see this snake wala necrosis, that is serpentine necrosis. So I'm talking about wildlife, I'm talking about butterflies, I'm talking about snakes. That is glioblastoma. And for NEET and INI-CET students, GB shows you GB. That is glioblastoma shows you glomeruloid bodies. That is glioblastoma. Coming back, you could see the snake. As soon as you saw the snake, glioblastoma, IDH, wild type. Coming to the next one, some of you answered co-deletion 1p19q. No, that is an oligodendroglioma. Carefully look, oligo, it has the andas in it, the O's in it. So this is obvious that it will show you the fried egg appearance. That is okay. If you are asked what is the most common mutation, it is going to be IDH mutant type. But if you are asked which other mutation can be seen, that is going to be co-deletion 1p19q. See, chota number, chota arm, big number, big arm, don't mess up 1q19p and all, no. Small number, small arm deleted, big number, big arm deleted, co-deletion sounds pretty bad. Two chromosomes are getting deleted, but actually this patient is going to have a good response to chemotherapy out here. Coming to the next, maybe before I move forward, you can answer one question. There is a 40-year-old female presents with worsening headache since 8 months. A left subfrontal mass is resected. Microscopy shows whirling of the tumor cells with progesterone receptors. I mean, a brain tumor which is hormone dependent is only one, and that is meningioma. What is, now they've asked you based on this, which other finding will you see? Over here, it's not all of the above, although you want to. So I've told you glomeruloid bodies are seen in glioblastoma. Rosenthal fibers are seen in pilocytic astrocytoma. Samoma bodies are seen in meningioma, and that is exactly what I had to teach you. Meningioma is more common in females because progesterone receptor ka dependence hota hai. So if they say that the headache is more during pregnancy, the tumor size increased, or maybe related to menstrual cycle. So if it is associated with menstrual cycle, pregnancy, hormone dependence, they are telling you, that is meningioma. Guys, can you quickly tell me radiology का क्या sign होता है? Meninges से तो आ रहा है, very good. But what is that radiology sign that you see a tail coming out, which all of you are aware of? That is the dural tail sign in radiology is going to be positive. What do you see, ma'am, in meningioma? Everything goes goal, 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 which means the tumor cells are also going goal, goal, goal. That is known as whirling of the tumor cells. And who can forget the samoma bodies are also going goal, 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 right? So round tumor cells called whirling, round samoma bodies that I have. Whirling, they had mentioned in the question, whirling of the tumor cells, round samoma bodies I mentioned, and the adult tumors are also done. I lied to you that it was the last question, because how can I finish a session without this question? This always has to be the last question. The most common molecular alteration of this thyroid tumor, ye to baat karna hi hai na, which thyroid tumor is it? As soon as you see these empty nuclei, which thyroid tumor? Orphan annii nucleus, ma'am, and papillary carcinoma. You understand that it's my majburi that I have to teach you this before going. So before I actually go, papillary carcinoma, 1 minute ka time I'm going to take and finish it off. Tell me everything about papillary carcinoma thyroid in this slide. What is the first photo showing you? Khali nucleus, white nucleus, that is like this cartoon character Orphan Annie. So white nucleus, Orphan Annii nucleus. Is it a real finding or an artifact finding? It is a formalin artifact. It is not a real finding. Formalin artifact. Very good. Next one, ma'am, inside the nucleus you are seeing an inclusion. So that is known as intranuclear inclusion. Inside the nucleus, you are seeing a line that is known as intranuclear groove. Can I call this the coffee bean appearance, intranuclear groove? Yes. And lastly, who will forget the samoma bodies? Papillary carcinoma thyroid question is 3 question. Question 1, actually 4 question now that you are telling me, or 5, sorry. Question number 1 is genetics, because I kept remembering the subjects. Question number 1 is the genetics. Which mutation? It is the BRAF V600E mutation that you see. Any other history that is going to be very, very significant? There is going to be a history of radiation that is going to be significant. Very good, guys. Second, surgery से question आएगा तो कैसे आएगा? तो there will either be a history of a thyroglossal cyst या फिर there is a history of a thyroiditis, that is Hashimoto's thyroiditis. Done. Number 2, other than thyroid swelling, does it spread to the lymphatics? Yes, there will be a patient saying that thyroid में तो छोटा सा nodule था 1-2 centimeters, but the nodule on the lymph node has become like 4-5. Lymph node spread is very, very good or very, very known. And prognosis, good, bad, ugly or excellent. I mean, you know, my HOD used to joke about it that no one obviously asks God for any cancer. But if ever you are stuck in that situation and you have to ask God that, oh, give me this cancer, then ask for papillary carcinoma thyroid. Every HOD has this same joke to tell their residents. Reason being that this has an excellent 100% survival wala situation. So that is why it's one of the good cancers, if I can say so. But because you've done papillary, what is this photo, guys? This is follicular carcinoma thyroid. Now, why is the question coming in? I lied to you. This is the last question. Which of the following thyroid tumor that cannot be diagnosed on FNAC? And that is FTC, FMG ka favorite question. Why can follicular thyroid cancer not be diagnosed on FNAC? Because category says that there are 2 criteria for follicular carcinoma thyroid. One is that जो capsule है that has to be invaded, capsule में से tumor has to come out. And second, blood vessel में, can you see the tumor is sitting inside a blood vessel? So vascular invasion also has to be there. A tiny little FNAC needle, ma'am, FNAC needle will not be able to take out full thyroid capsule, full thyroid blood vessel. So if I can't see these two things, I can't give diagnosis of follicular carcinoma. So here they say that which is the tumor that cannot be diagnosed on FNAC? That is follicular thyroid. But don't forget something, that what is the most common mutation that you see in follicular thyroid cancer? That is the RAS gene mutation. And now I have one last question, because this is the summary slide on which I will leave you. For papillary carcinoma, you told me it was the BRAF gene mutation. Photos you have studied. For follicular carcinoma, you told me RAS gene mutation. Photos I have taught you. Anaplastic, you only need to know the word anaplastic tells you very, very bad. Medullary carcinoma, there is one song that always I have taught you, and I want to finish the session on a song. And that song is RET 10 Med Men, which tells us RET is the name of the gene, chromosome number 10, Med is medullary carcinoma thyroid over here, and the tumor syndrome with which it is associated is going to be MEN2A and MEN2B. I have to finish the session on a song, and for you being so nice and kind and patient with me. But one last thing, what is the tumor marker of medullary carcinoma? That is calcitonin. If calcitonin decides, today I'm leaving as a bridge for tomorrow. If calcitonin decides I want to deposit as amyloid, which amyloid? Acal amyloid. And if I want to see amyloid, which is the stain that I will be using? Back to where we started from, ma'am, you will be using Congo red, and you will be seeing the apple green birefringence. So now in the exam, please note papillary BRAF mutation, follicular RAS mutation, medullary RET mutation. But ma'am, RET mutation तो हमने Hirschsprung's disease में भी पढ़ा था. Truly, I promise ये last चीज है. Hirschsprung's disease में भी पढ़ा था RET mutation. Now you are saying RET mutation in medullary. Is there a difference? Yes. In Hirschsprung's disease, what is the problem with the ganglion cells? Pediatrics में पढ़ा. In Hirschsprung's disease, ganglion cells are absent. Why? No ganglion cells, because the RET gene is not working. There is loss of function of RET gene. That is why the ganglion cells also get lost. Whereas in medullary carcinoma, why is cancer happening? Something having excess, because there is a gain of function of RET gene. RET is working more, and that is why cancer is happening. So if RET gene stops working, Hirschsprung's disease. If RET gene starts doing overtime and starts working a lot, that will result in medullary carcinoma. Finally, that's the end, truly the end from my side. And you have seen this slide before in every LRR. Means the last 4-5 slides that I've added, all ovarian tumors, testicular tumors and breast tumors. Unka photo I have already, I'll give you a quick scan through. Ye photos I have already added, abhi nahi padna. You have to study these when you are done with the gynae LRR, which you are done with the surgery LRR, and everything is over. Then you're like, theek hai ma'am, then I'm going to go and sit and read these bonus slides, because then that will integrate pathology with every other subject. Sorry for being so
overtly overtime, but this is the best that I could squeeze it into. But yeah, tomorrow I think I will try. I mean, I can only try that I can give you a shorter session tomorrow, but I don't want to miss out on any content in that race of finishing it early. So tomorrow we'll have a session at 12 in the afternoon. My advice is that although it's always more convenient for all of you to view it at a 2x speed later on, but I personally feel that if you have that, thing that someone is sitting live, it's always better to attend and finish it off. It might take an extra hour, but I also know that even on 2x, you're going to take the same amount of time. The better thing is that over here you are interacting with everyone else. So yeah, now any other questions? Because now of course I've ignored a lot of your miscellaneous questions, but agar kuch hai which INI ke extra topic tomorrow when I finish every subject I will give you a list. Okay, so path ke end mein I'll give you a pathology list and micro ke end mein micro list. That's how it works. But yeah, till then just keep studying and I'll give you that list when we finish tomorrow. LRR type part 3 will become a little too much, because then that will, like, imagine a 3 plus 3 plus 3, like 9-10 hours, we are almost closing into a rapid revision then. And then the entire essence of LRR is lost. But I'll try my best that I can give you a detailed diagrammatic HEMAT orientation tomorrow. I'll try my best to squeeze in whatever I can into that session. Okay. Prof. Dr. Sufyan, we are resuming from May, and that is, yeah, I know there has been a delay, and that was only because of the version X launch that was ongoing. But May, June, there are going to be extensive classes, and May, June, July, of course, till your prof is there, and we are going to have back-to-back sessions, and we will finish the syllabus. No, there's no need, Dr. Aspiring, no need to switch your notes. Whatever you have, stick to it. That's it. Never change your notes. Versions keep coming, but if you've spent 1-2 years in reading notes, now in the last 3 months, 2 months, changing your notes can be disastrous. So no, you don't have to change your notes. Okay. Congratulations, Dr. Mohit. 2110 and 210 is a great score. I mean, I don't even need to say it. It's amazing. PDF ke liye, Dr. Junaid, you will have to let me stop the session. I will stop the session, then I'll have to convert it into a PDF. 10 minutes mein you will get it on the Telegram group. Homework already de diya. 1, we hate PSM mnemonic for flea bitten kidney, you will have to write in the comments. Second, A beta lipoproteinemia ka jo gene mutation hai, that you will tell me tomorrow when I come to that same question again. 2 more homeworks you have to do. 1, I am not going to again teach you all the mnemonics of autosomal dominant, recessive, ye sab, because then I'm wasting time. So all the Mendelian disorders ke mnemonics you will do from rapid revision videos, and all the hypersensitivity ke mnemonics, because I don't want in LRR we are sitting and doing mnemonic ka ratta. That is going to waste time. So 2 homeworks for you to study and come for tomorrow is all the Mendelian disorders ka mnemonics and all hypersensitivity reactions ka mnemonics, because repeating it is not going to make any sense. Pseudomyxoma peritoniae is paraneoplastic, Dr. Afreen? No, that's a kind of a metastasis. That is when the appendix or the ovarian cancer spreads to the peritoneal cavity. So it's not paraneoplastic. Thank you so much for everyone who is writing such nice messages. I mean, it's not becoming possible to reply to you individually, but I have a habit of replaying the entire chat once the session is over, and I would go through each one of them, whatever I've missed out. So thank you so much. Homework I've already given. RR plus PYQ, ma'am, is it enough? Pakka. But RR matlab it should be on your tips. If I say papillary, your thyroid it should start in your entire chapter, should start in your brain. That's how thorough you should be. See, when you're taking a shorter version of any subject, then give your 200% to it. First best way of cracking an exam or any exam is main videos na. अब अगर हम वो नहीं कर रहे हैं, then that doesn't mean we have to fall short. We have to make the best out of what we are doing. So if you're doing rapid revision and PYQs, then the rapid revision should be done in such a way that then no one can beat you. That should be your entire motive behind it. Okay, Dr. Amit is asking what's PIZZ? Dr. Amit, that's the way you write about alpha-1 antitrypsin. Alpha-1 antitrypsin enzyme is written as PI, and if they write PIZZ, this means that's the genotype of a person who has a disease. If they write PIMM, that means the person is normal. If they write PIZZ, it means the person has the disease. Okay. Dr. Jency, about LRR for all 19 subjects, and would you be able to score above 100? I mean, above 100 karke kya milega na? Above 100 score in FMG is not going to help you. You need a 150 plus. So only LRR, no. You have to prioritize. If you're reading it for the first time, and even if you're starting now, then prioritize that for certain big subjects, at least do the rapid revision. And then for the shorter subjects or for subjects which are too problematic for you, you come to LRR. Aiming 100 in FMG is as good as not aiming for anything, because then 150 to aim rakhna hi rakhna hai, right? Quizzes will start, Dr. Vikalp, after LRR, not before that. Okay. Perfect. I think we are pretty much done. Yeah, Dr. Ahmed, regarding INI topics, tomorrow I'll tell you. You need to do flow cytometry, electron microscopy, and all of these. Tomorrow I'll be telling you with the source from where you have to study. Okay, Dr. Arvind, yeah, I'm sorry. Thank you for reminding me. There was a question that you'll just have to give me 1 second for me to be able to get back to that topic of MGN which you had pointed out. And okay, so Dr. Arvind, you are right. In fact, none of these options are wrong. All of them are correct. You know, these antibodies have also been found in neonatal MGN, and the deposition is also subepithelium, but that's not the question now. The question is, which of the following is likely associated with her condition? Maybe, yes, there is some deposition in her patient, in this patient, but why? They've asked you what is likely associated with her condition, which antibody has led to this, and that antibody has been phospholipase A2. So practically speaking, Dr. Arvind, all 4 options are correct, but what the examiner has asked us is what we have to focus on. Okay, so I think we are settled, and I know I missed out on a lot of questions while I'm taking other. No, we are back to the same question, ma'am. Are you taking pharma? Not at all. Big no, point blank no, no ifs and buts there. Pakka, not taking that subject. Yeah, if I missed out on any questions, the link is open. Put your comments below and I will read them before 12 o'clock so that I know if you want anything to be added or deleted in tomorrow's session at 12 o'clock, it can be done. And we'll be meeting at 12 noon sharp. Okay. Yeah, so ITP, TTP, HUS, kal pad lein Dr. S, because that's a hemat topic. We'll take care of that tomorrow. Okay, yeah, go ahead. Mendelian disorders ke mnemonics, hypersensitivity mnemonics, and like Dr. Nurav says that ma'am, pasta fried rice, pasta fried chawal for dinner. So again, an internal reference which only we would know, but I hope all of you are going to study it. So all the very best. Thank you so much for joining in. See you very soon. That is just tomorrow at 12 o'clock. Thank you guys.